morning to all of you. I welcome you all to the International Workshop and CME on the Fertility Preservation in Childhood Cancers, Life Beyond Cancer. A CME on a very pertinent and thought-provoking topic in present context has been designed and organized by the Division of Reproductive Medicine, Department of Obstetrics and Gynecology, AIIMS, New Delhi, under the aegis of Fertility Preservation Society of India and IVF Research Society. With all the stakeholders from pediatric oncologists, social scientists, and counselors, all the thoughts converging at the same point to make life of childhood cancer survivors worth enjoying. Na asti matri samachaya, na asti matrisam gati, na asti matrisam trana, na asti matrisam prapa. Motherhood or parenthood is designated in many cultures, including ours, as an indicator of completeness and divinity. The increasing cure rate of childhood cancers had led to a vast population of survivors having to face the late adverse effects of oncological treatments, and with fertility impairment being one of the most issues. This CME will throw light on the common status of fertility preservation measures for pediatric patients undergoing gonadotoxic treatment and focusing specially on the challenges that remain to be solved in order to implement this fundamental service. So we begin this academic feast with the first session. For the first session, I invite the esteemed panel of chairpersons. Professor Anita Singh, ma'am. Ma'am is the professor, Department of Obstetrics and Gynecology at AIIMS, New Delhi. Dr. Sabita Gupta, ma'am. Ma'am is the head of Gynae Oncology Division, Medanta. She is the first gynecologist in India to perform robotic gynecological surgery for cancerous and non-cancerous gynecological conditions. Ma'am's numerous specializations include gynae oncology, colposcopy, advanced gynae laparoscopy, robotic surgery, and hysteroscopy. She is the president of AIIMS India, a prestigious organization, and she has numerous contributions and accolades in the field of gynae oncology. Over to you, ma'am.
Thank you, Dr. Nilajli, for the kind introduction. And let me begin with thanking Dr. Nita and the organizing team for having me here for this very important and prestigious CME on fertility preservation in childhood and adolescent cancers. While dealing with the adolescent and childhood cancers, the focus and the stress was more so on improving the survival. Now we know that we have attained good survival rate, and we can see the curve flattening. Now there's a sharp focus on improving the safety of the treatment and the quality of life. When it comes to the quality of life, fertility forms a very, very important aspect. And so here we are all gathered to listen to our stalwarts and know what all we can do in this field. To get the ball rolling, I'll invite Dr. Rachna Seth, and she is Professor and Chief Division of Pediatric Oncology, AIIMS. She chairs Indian Pediatric Oncology Group Late Effects Committee, PHO Chapter, Indian Academy of Pediatrics. Her area of interest is mainly acute leukemias, histiocytic disorders, retinoblastomas, and late effects and survivorship. Currently, she is steering the first national multi-center survivorship registry in India. And she'll be speaking on the first, please. Can we come to the, overview of incidence, survival, and fertility risks in childhood and adolescent cancers. Over to you, Dr. Rachna.
Okay, good morning, everybody. At the outset, I thank the organizers for arranging this CME on a very, very important and much needed topic, particularly for us pediatric oncologists. And also I thank you for inviting me to deliver this talk. So, as you all know, the global burden of cancer shows that cancer incidence rates continue to increase worldwide, which is also true for pediatric cancers. It is also true that advances in treatment strategies for childhood cancers has resulted in a growing population of childhood cancer survivors. Also is the fact that almost 70% of these patients are going to emerge as childhood cancer or adolescent cancer survivors. What is important and more important for us and related to the topic that we are going to deal today is that 1 in 10 cancer patients is going to experience a fertility or a reproduction related concern. This is attributed to gonadotoxic effects, maybe of surgery, chemotherapy, or radiation. And also to compound this, there is a component of sexual dysfunction which is related to the cancer itself. And also combined with this is a large component of social and psychosocial issues and physical issues that combine the gonadotoxic effect of surgery, chemotherapy, as well as radiation. So, I think you all would know this better, that fertility preservation has established as a new field in reproductive medicine. But for us pediatric oncologists, for child and adolescent cancers, it is still developing also in the developed world. And for us in India, we are far behind. So my overview of presentation today is going to flow as I'll be dealing with the spectrum, incidence of childhood adolescent cancers, some basics, aspects of survivorship, what is the price of cure that we give to our survivors, and then of course, some aspects of fertility risks. The global incidence of disease for our patients in the age group of 0 to 19 years is estimated to be about 400,000 new patients. 400,000 new patients are seen annually. The reported incidence in the high income countries continues to be very high as compared to that in the low and middle income countries. But what is also important is that there is an underreporting in the low and middle income countries. Underreporting of the registries. So as I was telling you, that the reported incidence in the high income countries is very high as compared to the low and middle income countries. And approximately 80% of the global burden of childhood and adolescent cancer is shared by low middle income countries. And there is some still inaccuracy in the data. The reasons being that the cancer registries do not cover the entire population. They are ill maintained and there is not a complete representation of the burden of childhood and adolescent cancers. Many patients go undiagnosed. There are competing causes of death, particularly pertaining to the national priority as regards diseases are concerned. There is often a malfunctioning of the healthcare systems. There is lack of resources for diagnosis and treatment. And also there is a component of misdiagnosis, which actually underestimates the reporting of childhood and adolescent cancers in low and middle income countries. The spectrum and incidence. It's just not moving actually. Slides are not moving. We're not going by this, no? I want to go back, no? So you want to go back. Yeah, and forward is this? Yes. Okay. It's not moving actually, not going ahead. Sorry for this technical glitch. So the estimated, this is just to show the representation that most of the reported incidence of childhood cancers is seen in the high income countries, and there is underreporting in the low middle income countries. So if you see the distribution of childhood cancers in the two major age groups that we will be dealing, so if you see the red bars, which indicate that the age group from 0 to 15 years, and predominant cancer load that occurs in the age group from 0 to 14 years is shared by acute lymphoblastic leukemia and followed by CNS tumors. Whereas if you see the gray bars, that denotes the childhood cancer incidence in the age group between 15 to 19 years. So besides leukemia and lymphomas and CNS tumors, the greater burden of cancers in the adolescent group is shared by lymphoma and also germ cell tumors. So it is important for us to know that why the spectrum of diseases in the various age groups is important, because the treatment modalities are going to be different. The biology of disease is going to be different. The counseling content, particularly with reference to the reproductive counseling, is going to be different. Also, the prognosis is going to be different. So we need to be aware of the spectrum of childhood as well as adolescent cancer that typify the particular age groups. So there is also ethnic variation in the childhood cancers. So this is a busy slide, but what I need to actually emphasize is that in the Asia-Oceania group and the South America group, there are the predominance of leukemia and GCT, which are commoner tumors. But if you go into the sub-African nations, it is predominantly the lymphoma group. We all know that Burkitt lymphoma is very, very typical of the African countries. So besides the Burkitt lymphoma, soft tissue sarcomas and the renal tumors also become predominant cancers in the African countries in the age group of 0 to 14 years. Also, similar patterns have been noted in Africa in the adolescent group, in the age group of 15 to 19 years, where soft tissue sarcoma, renal tumors become a predominant age group. What is the Indian scenario? Every country has some typical presentations of as regards cancers is concerned. The burden as shared by Indian childhood and adolescent cancers is that we have approximately 1 million new cancer patients that are diagnosed annually. 3% of these are shared by pediatric cancers, and these translate to about 50,000 new pediatric cancer patients annually. In a recent survey done in India, which was published just in 2021, it was shown that 5 states in India, which include Uttar Pradesh, Bihar, Maharashtra, West Bengal, and Madhya Pradesh, are taking the major burden of pediatric cancers, meaning thereby that as you saw in the Western countries, so also even within one country, there are regional variations in the tumor burden that is shared by various states. We comprise almost 20% of the pediatric cancer burden globally. It is dismal to see that 60% of the newly diagnosed cancers succumb to the disease in India versus only 10% as seen in the developing countries. So just to tell you, how do we fare? How does our spectrum change from the other countries? So this is the bars that you see is just a replication of what I just discussed, that common pediatric tumors, conventional teaching is that it is predominantly ALL followed by CNS tumors, followed by lymphoma, and then the other solid tumors take a toll. But if you look at our center, this is our reflection. Our major cancer types are leukemias, ALL, AML, closely followed by retinoblastoma, then the lymphoma, and then the other solid tumors. Then again, there is a component of referral bias. So these are all very important factors as to what type of cancers a center is going to see. Ours being a referral center, tertiary center for cancers and for retinoblastoma, we see one of the major burden of retinoblastoma patients. Coming to the next aspect of what are the causes of mortality in children and adolescents as far as cancers are concerned. So if you look at this group, the first bar, which is the 0 to 14 groups, it is predominantly the CNS tumors, which comprises almost 1/3. Although they are the commonest tumors, but then the mortality also is shared major by these tumors. CNS tumors closely followed by leukemias that comprise almost 25% of the overall mortality. Similar data is there for even the adolescent age group, where leukemias take about 25%, but bone tumors become another important, and also the CNS tumors. So we need to be aware which tumors need. So all these actually help us realize as to which tumors need focus, what is the trend of survivorship, what is the trend of mortality, and these data form important references. So this is the global estimate of mortality just recently published in the 0 to 19 years. So mortality is lower in the high income countries, as you can see the orange bars. And of course, the major toll of mortality is shared by the middle and low income countries. Recent WHO has just published in 2021 the data. As you can see, the trajectory of mortality of this is pertaining to both the entire 0 to 19 years group. How you can see in the developed country there is a persistent fall, and we are faring far better as compared to the developing countries. And there is a slight increase also, but then this can be interpreted as an increase sort of incidence with better modes of detection of childhood and adolescent cancers. Coming to the last and the most important aspects as regards the epidemiology before we move to the reproductive aspects is the survival. This is something that interests all of us. The overall survival of childhood and adolescent cancer is increasing, and this is really, really satisfying. And 5-year survival of childhood cancers has increased over the time. And in the high income countries, it is to the tune of almost 80%, with middle income countries touching 55 and low income, it's low to about 40%. But I wish to share this very recent WHO data, which is almost 2021, very recent, and it is just quoting a figure of 15 to 45%. But mind that this is actually the overall data. Individual centers are doing far better. Survival is also different by the type of cancer that we deal with. So it's far better for the lymphoma and leukemia group. For example, in the 5-year survival for leukemia lymphoma in the high income country would be to the tune of 80 and 90%. Whereas for the low income country, it falls drastically to 36 to 55. For other difficult to treat tumors, CNS tumors, although being the second commonest cancer, both in the adolescent and the pediatric age group, the mortality is far higher and the overall survival is very, very dismal with, comparing if you look at the high income and the low income, it is almost 71 to 27%. So these are the trends. This is data of the SEER, that is one of the major important, most authentic epidemiology groups of the US, the National Cancer Institute. This is Surveillance Epidemiology End Result Program, which actually shows the 5-year survival data of 2 age groups separately. So if you see these graphs, the red ones, the maroon ones represent the 0 to 14, and the blue ones are the adolescent age group. So by and large, they are comparable. The disease-wise, there is comparison of the mortality, but with certain diseases like ALL, Ewing sarcoma and rhabdomyosarcoma, the adolescent fare less as compared to the pediatric population. This is the estimated childhood 5-year net survival country-wise, and you can see in the high income countries, survival is almost approaching 80% versus 30%, 50 to 30% in the low middle income countries, and India is at the overall survival in India is almost to the tune of 25 to 50% with variations seen in individual centers. So with improved survival, where are we dealing with? There is a price of this cure that we actually need to face. So what we need to realize is that with overall advancements in diagnostics, therapeutics, and management, the overall survival is increasing and it is almost touching 80% overall for all tumors in the developing world, and individual centers, even in the developing countries, are doing very well and touching these figures. And also we are having a growing population of survivors. But at the cost of that, what we need to realize that almost 70% of these cancers are actually around 20 years, and 1 per 530 young adult in the age group of 20 to 39 years is actually going to be a childhood cancer survivor. But these survivors are at a very high risk of reporting chronic health conditions. And there is a spectrum of health conditions which these survivors are likely to have. They could vary from post-traumatic stress disorders. It is a premature imaging, that is premature aging. The survivors are known to age faster as compared to their age-matched normal population. There are galaxy of psychosocial issues that accompany survivorship. Then the most important aspect is the late effect, which all is pertinent to the reproductive aspects that we are to discuss throughout the day. So what are late effects? Late effects are unrecognized toxicities that are absent or subclinical at the end of therapy. They become manifest months or years later and they will persist beyond 5 years or even later from the diagnosis. So this is one aspect which every pediatric oncologist has to be aware of when you decide on treatment for a patient. And almost 2/3 of our survivors will experience one late effect, and 1/3 of these is going to be life-threatening or life-altering. What is relevant for today's discussion is that 1 in 10 of these patients are going to have a fertility or a reproduction-related issue, concern, which is important, and it is particularly going to be pertinent to the ovarian or testicular function. If you look at the spectrum of late effects, it could be impairment in growth and development. There could be a battery of organ dysfunctions, be it cardiac, endocrine, hepatic, musculoskeletal. There could be a wide range of psychosocial issues. There could be cancer related, where the primary tumor could come back, or there could be a second neoplasm that could come up, or there could be this broad group of fertility and reproduction late effects, which encompass the spectrum of fertility issues, health of offspring, disorders of sexual function. But of course, today, mostly we will be dealing with fertility issues. What is the genesis of these late effects? So we need to understand why these late effects are occurring so that we can plan the treatment of these children far better. It could be either a result of direct therapy, which the patient has received, either be it surgery, chemotherapy, radiation, or any other direct effect of the tumor per se, or the injury that has occurred in the patient. It could be subclinical at the onset, and it becomes overt with any failure of the compensatory mechanism. There could be some lifestyle changes which could occur at the adolescent or in the older age group. A big component is being shared by the genetic predisposition, and of course, a lot of unexplored causes are being projected, are being thought of, which still are going to unveil as time unfolds. So there's a big need of awareness and sensitization towards occurrence of late effects. Coming to the reproductive outcomes, there are two major aspects. One is the impaired hormonal responses, and the other would be infertility. So the variables that seem to be most important would be the diagnosis per se, the malignancy that the child or the adolescent has, what is the patient's age at diagnosis, the cancer treatment that has been given, the type of chemotherapy, the drugs that we use, the doses that we use, the radiation dose, field, the fractions that we use. This forms one of the most important factors that are responsible for the reproductive outcomes, be it infertility or other dysfunction. Cancer per se also is known to reduce the fertility because it has some acute as well as chronic effects on the host. Fertility also is affected by some other aspects which are inherent, which are not dependent on the cancer per se, and which you as gynecologists would understand this better. These are ovulation problems, endometriosis, polycystic ovary disease. These compound the treatment that we give to a patient. And of course, there is a component of genetic predisposition. Infertility, actually, second to the neurocognitive deficits, remains one of the most important life-altering treatment effects that is faced by a childhood or adolescent cancer survivor. The modalities such as surgery, radiation, and chemotherapy would actually affect the hypothalamic pituitary gonadal axis, and this would ultimately result in compromising the reproductive outcomes. If you combine these modalities, your gonadotoxic exposure, the effects are compounded. So whatever effect one modality of therapy is going to result into, it gets far compounded when the modalities get combined, as you will see in the presentation. Just to give you one example of surgery, so I'll be just talking about surgery, radiation, and chemotherapy subsequently. So if surgery, where you just take an example of germ cell tumors, where you would do a surgery on a gonad. So surgery, if you see, it would reduce the germ cell numbers. You give chemotherapy and radiation, it compounds the number of germ cells. Secondary or compounding or associated with the surgery, there could be nerve damage, there could be vascular injury, and a component of sexual dysfunction would come into. All would compound your effects of gonadotropic toxicity in these children. Wilms tumor patients are known to have hydrocele. CNS tumors have secondary hypogonadism, and also many of these following surgeries would have impotence and retrograde ejaculation. Coming to the chemotherapy, if you focus on the males, the testis, the chemotherapy would particularly be the alkylating agent. It's a big list. I'll be sharing it shortly, but I think there are sessions dedicated to that later. But all commonly used drugs, which you all are familiar with, cyclophosphamide, ifosfamide, thiotepa, platinum-based, procarbazine, all these drugs are very commonly used drugs for our childhood and adolescent cancers. They cause actually damage to the DNA and induce apoptosis. The two target areas in the testis would be the germ cells and the Leydig cells. And what is seen is that the germinal epithelium is more sensitive to the radiation and chemotherapy effect as compared to the Leydig cells. That is the reason that often the spermatogenesis gets affected far more earlier as compared to the sexual maturation. And we really need to be aware of this aspect, because while planning our chemotherapy or radiation, one function may get affected and the other function may still be preserved. This is a dose-dependent gonadotoxicity as far as the chemotherapy is related, and it is, immaterial regarding the pubertal status. So any dose beyond 7.5 gram per meter square of cyclophosphamide or equivalent will result in prolonged or permanent azoospermia. Any dose less than 7.5 gram will result in gonadal injury, which will be reversible after a few years of therapy-free that have elapsed from the time that the chemotherapy was given. And this would be in majority of the patients. Doses less than 4 gram per meter square or equivalent, which actually result in a reversible azoospermia, and normospermia would be the rule for most of the patients. So how we see that doses are so important as to when you plan chemotherapy for your patients, and this gets compounded. So subsequently, after 7.5 gram per meter square, as the doses get escalated, maybe by 1 gram per meter square, the risk of azoospermia increases by almost 10 to 25%. So this was regarding the testis. Coming to the females, so chemotherapy, the same agents would actually cause depletion of follicles. Two major forms of the deficits that would occur in the females would be acute ovarian failure and premature menopause. You would know these definitions much better, but of course, ovarian functions get affected for us in acute ovarian failure, and there's a premature menopause by 40 years when we say that it is a non-surgical or a premature menopause. As regards doses, what we saw was 7.5 gram for in females. Doses are higher, at least to the tune of 11 gram per meter square. Once you use those doses, be it for a solid tumor in any patient, it is most likely that the outcome for reproduction at the level of offspring is going to be affected. Coming to the third aspect of radiation, it generally would affect somewhere in the hypothalamic pituitary gonadal axis. So if you focus in the cranial artery, so once you use doses of about 18 to 24 grays, which were used to either treat or prevent CNS leukemia, what was seen was there was altered pubertal timing. This was the rule earlier, but currently with advancement and understanding of these concepts, most protocols currently have given up cranial artery as a prophylactic measure. Only therapeutic artery is given for patients who have CNS disease, which is positive. But this was the earlier. We are still facing the brunt of this because many of our survivors who are coming have received prophylactic cranial artery earlier. And some have also received 18 grays as prophylactic cranial artery. Also, the other thing that we need to realize is that for CNS tumors, our radiation doses are much higher, exceeding even 30 grays. So here, delayed puberty is going to be the rule. And what I need to really tell you is for CNS tumors, it is multimodal. Here, radiation is one, surgery would be other. You would be using chemotherapy, temozolomide, etc. All these would compound, and the deficits on reproductive function, on infertility are really, really tremendous. So coming to the radiation, what we just talked was for CNS, which was one important organ, then coming to the testis. So any radiation to the pelvis, to the testicular area, or to the lumbosacral spine is going to impose some radiation hazard to the testis. So this will cause a germinal loss, ultimately resulting in testicular volume and sperm production reduction. And this would translate into azoospermia. So this is also a dose-dependent phenomena, as you saw with chemotherapy. So with doses of 1 to 3 grays, azoospermia is going to be reversible. With 3 to 6 grays, it may persist for a few years, but then is likely to reverse, as we saw with cyclophosphamide doses. With doses of 6 to 8 gray exceeding these, it is going to cause an irreversible injury to our gonads. The other hormone function, the other function of the testis, as I told you, was regarding testosterone production and sexual maturation. The Leydig cells are far more resilient and they would tolerate higher doses before this gets compromised. So for just to give you an example, if you use 20 gray of radiation, then it is going to compromise both your reproductive as well as your reproductive function, as well the propensity to produce spermatozoa, as well as your sexual maturation is going to be affected. Ovaries are extremely sensitive to radiation, and the two hazards or the effects that we saw are almost similar to what we saw in chemotherapy. It's acute ovarian failure and premature menopause. But mind that the doses are really, really different. We need to be aware that if we are using lower doses, we are more likely to cause a premature menopause versus when we use very high doses, it is likely to cause acute ovarian failure for these patients. And combined modality is going to be, it's going to exacerbate the gonadotoxicity. So essentially, virtually all therapeutic radiotherapy that you use for our patients, which is directed to the abdomen or pelvis, is going to be gonadotoxic for the patients. So just to share a few studies, this is an important childhood cancer survivorship cohort, which is a US-based cohort, and it is actually following survivors for 3 decades or more. And it is one of the most authentic bodies which is providing data on survivorship. And these evaluated almost 3,300 eligible women for reproductive outcomes. So 6.3 reported ovarian failure at 5 years from diagnosis, and the risk factors were almost similar. What I just discussed was high dose of radiation and chemotherapy like procarbazine and cyclophosphamide, commonly used for our solid tumors. Other component that was seen was the non-surgical menopause or premature menopause was seen in almost 8% of eligible women, and risk factors were older age, primary diagnosis of Hodgkin's lymphoma, and when we were using a combination of chemotherapy and abdominopelvic radiation. Another important study group is the St. Jude Lifetime Cohort. You would have heard of the St. Jude's Cancer Hospital, a real pioneer in putting forth a lot of research for acute leukemia particularly. So these have actually evaluated dose-related decline in sperm concentration, and also the concept of increasing dose that compounds the toxicity as regards spermatogenesis is concerned. And there's also a concept of that there is no safe dose. So even although we talk of these doses, but one must realize that even a minuscule dose of these gonadotoxic chemotherapy that is being given to these children would require a surveillance as regards toxicity is concerned, because there are a lot of genetic factors. So in essentially, there is no safe dose of these alkylators. Another important graph which I like to share with you was because I've been talking of combined gonadotoxic effect. So this is the first graph that you see with respect to premature menopause, where only you use A is for alkylating agents and AP-RT is for abdominopelvic RT. So in this first graph where you use only alkylators and you don't give RT, the next graph is where you use RT and you don't give alkylators. But when you combine the two, you just see how important the combination becomes, and almost you achieve almost 30% of the cohort had gonadotoxic toxicity in the form of premature menopause. Indian data is scarce as regards reproductive function and infertility. We are really, really behind, but a lot of interest has been generated. And in the times to come, more meaningful data should emerge. A small study was conducted by Dr. Puneet on only it's a small population of 21 childhood cancer survivors with a median age of 18 years. And
Dr. Rachna. Yeah. The organizers are requesting that if you could hurry through.
Okay. So I'll just quickly hurry through. So just give me, I think 5 minutes. I would
Sure,
take to
please.
wind up. Yeah.
Please.
So this was seen in about 3 patients and only 14% had reproductive dysfunction. In another study from South India, which was conducted in Ariyar, they also found that in their cohort, the late effects were evaluated, and where they found almost 25% of their patients had gonadal dysfunction. And major drawbacks that were seen or comorbidities that were seen was oligospermia or azoospermia in the males, and gonadal dysfunction, amenorrhea, etc. in the females. We also conducted a study on 300 survivors, but this was more tuned to finding the overall incidence of late effects, and gonadal function was assessed in 22 patients. These patients were of Hodgkin's lymphoma and ALL, and we found was FSH and LH was high in about 9 patients. 5 of them had testosterone levels which were low, suggestive of hypogonadism, and azoospermia was actually seen in one of the 2 testes, the high incidence, and this child, and who's actually an adult, was treated with chemotherapy that caused a permanent irreversible sterility. Coming to the hematopoietic aspect of reproduction, it would be, can I just complete the thing in 5 minutes? Okay. So here, I'll just go quickly. So in the, as regards the transplantation is concerned, so our conditioning treatment becomes important, whether it is TBI or it is the total body irradiation. It affects more the germ cell function as compared to the testosterone production function. It is true for both, whether it is TBI or it is the chemotherapy where you use cyclophosphamide or other alkylators. Pregnancy outcomes again become a concern, particularly with respect to that it's the radiation that affects the outcome far more, and it causes the impairment in uterine growth, development, and blood flow. And we see manifestations like hypertension, fetal malposition, fetal loss, abortions, preterm labor, and low birth weight, which are seen in our, as pregnancy outcomes. And this is more attributed to the abdominopelvic radiation that we see. And it is also seen particularly in our Wilms tumor survivors. So I'll just skip this in the interest of time, because even in the, as regards the hematopoietic stem cell transplantation survivors also, the pregnancy outcomes were quite dismal, and they had a high proportion of spontaneous abortion, preterm delivery, particularly low births and very low birth weight babies. Chemotherapy doesn't affect much the outcome of the offsprings, and that is, yeah, so I think I'll just finish with this. There is one component of genetic predisposition syndrome which is important, and I think this would be discussed in the subsequent lectures. So the tumors, just mention the tumors which are important as regards the fertility risks are concerned. These are acute leukemia, relapses, lymphoma, bone tumors, soft tissue sarcomas, renal tumors, CNS tumor, and transplant patients. So there is a big list of tumors that actually result in gonadal and dysfunction and the associated risk of fertility. A list of chemotherapy that has already been discussed is responsible. These are all our patients who have been treated and actually have one of the hazard, and they have one of the deficits of reproductive dysfunction. And I think I'll skip this, but I've already discussed this, these issues with both sexes, with females, where you find impairment of puberty, various ovarian and failures, premature menopause, deficits of uterine insufficiency, vaginal fibrosis, sexual dysfunctions, issues with our newborns, and also azoospermia, etc., and sexual dysfunction in the males. And the surveillance needs to be very strict with our survivors so as to improve their quality of life. So to just summarize, survival of childhood and adolescent cancer is increasing, resulting in a growing population of childhood and adolescent cancer survivors. Late effects are a concern, and treatment protocols need to be selected with great care. Also, the adverse effects of cancer treatment on reproductive outcomes should be anticipated to address and reduce the late effects. There's a tremendous need for sensitization and awareness, and wherever possible, fertility preservation techniques should be resorted to after detailed counseling. And these fertility preservation techniques actually need to be accessible and affordable, and there's a need for long-term surveillance and follow-up at the after-treatment clinics. Thank you.
Thank you. Thank you, Dr. Rachna Seth, for the wonderful lecture. And you have primed everyone for the, for the importance of this today's CME. I think we have our chief guest here. In a short while, he'll be here. So we'll take the questions later on, if at all, or maybe you can put them in the chat box.
Thank you, esteemed chairpersons and the speaker, for this enlightening session. We'll shortly move on to the inauguration ceremony. We now begin the inauguration ceremony. For this, I invite the esteemed panel of guests to the dais. First and foremost, I invite Honorable Professor V.K. Paul, sir, member of Niti Aayog and our chief guest today. Welcome, sir. Professor Randeep Guleria, sir, Director, AIIMS, New Delhi, and our guest of honor today. Welcome, sir. Professor K.K. Roy, sir, Professor, Department of Obstetrics and Gynecology, AIIMS, New Delhi. Dr. Nalini Mahajan, ma'am, President, Fertility Society of India. Dr. Kavita Rajasekhar, Senior Scientist at Department of Health Research, Ministry of Health and Family Welfare, Government of India. Professor Anita Singh, ma'am, Professor, Department of Obstetrics and Gynecology, AIIMS, New Delhi, and the organizing chairperson of the CME. Thank you, esteemed dignitaries. I now request Dr. Garima to extend floral welcome to Professor V.K. Paul, sir. Dr. Ankita to present to Professor Randeep Guleria, sir. Dr. Priyanka to present to Professor K.K. Roy, sir. Dr. Nimisha to present to Dr. Nalini Mahajan, ma'am. Dr. Dipali to present to Dr. Kavita Rajasekhar, ma'am. And Dr. Shivangi to present to Professor Anita Singh, ma'am. Dr. Dipali, you can present to Professor Anita Singh, ma'am. This program is the brainchild of Professor Anita Singh, the organizing chair today. She is the Professor, Department of Obstetrics and Gynecology at the AIIMS, New Delhi. Madam is the pioneer in reproductive medicine at Government Health Sector. She is the ICMR DHR Fellow at UCL London. She did fellowship in IVF from Lübeck, Germany, and New York University. She is the recipient of the Foxy Young Scientist Award 2001, WHO Fellowship in Reproductive Health 2005, and Commonwealth Fellowship 2015. It was due to her untiring efforts that the IVF facility was started 15 years ago at AIIMS, and she is instrumental in starting similar facilities at other AIIMS in India. She is a prolific researcher and has published more than 160 papers in various index journals, presented more than 100 papers in various conferences and many international and national organizations. She is an editorial board member of many prestigious journals. She's also the ICMR Task Force member for regulation of ART and surrogacy in India. I request ma'am to render introduction to this program.
Thank you, Nilanjali, for this generous introduction. Respected Professor Paul, sir, Professor Guleria, sir, Professor K.K. Roy, sir, Dr. Nalini Mahajan, and all the faculty, chairpersons, delegates, students, friends, and other offline invited guests. Cancer is a challenging disease, but the beauty of life the beauty of life after cancer is worth living for. It's possible not just to survive, but to thrive and to live a wonderful life again. And difficult roads can lead to beautiful destination. These are some of the quotes by young cancer survivors. It's indeed an honor for me to welcome you all for this enlightening international CME on life beyond cancer, which is a very important subject in the present context. We have invited very learned and eminent faculty from across the globe to deliberate on this very difficult subject. I'm extremely thankful to Honorable Professor Paul and Professor Guleria for having taken out time for their busy schedule to be with us to inaugurate the CME on a very short notice. I would also like to thank Dr. K.K. Roy sir, who has taken in shoes of Professor Batla, who could not be here because she's recuperating from COVID. I really wish to thank all the guests, all faculty and chairpersons who accepted our invitation and have joined online and offline today on a short notice, because we hadn't thought that we will be able to hold this CME because of the COVID. The incidence of childhood cancers have steadily increased, and with approximately thousands of children being diagnosed each year. However, with the advent of more effective multimodal therapies, childhood cancer survival rates have continued to improve over past 40 years, with more than 80% of the patients now surviving into adulthood, which is really, really encouraging. And therefore, we are here to discuss fertility preservation has become a very important quality of life issue for many survivors of childhood cancer. And therefore, male and female fertility preservation options, both in prepubertal and adolescent patients, and the unique ethical issues surrounding fertility preservation in this vulnerable population is utmost important topic to be discussed. We have been providing fertility preservation services to the adult cancer patients at IVF facility of AIIMS since more than 10 years. And many of them have returned cancer-free and have undergone IVF with their frozen gametes and embryos and have enjoyed the joy of parenthood. But fertility preservation in adolescents and children is still a challenge for us, which we soon wish to overcome. And we are confident that we will be able to expand our services and aim to help these children and their parents for fertility preservation in our premier institution soon. Thank you very much.
Thank you, ma'am, for the kind introduction. I now request Dr. Garima to present a token of appreciation to Professor V.K. Paul, sir. Dr. Garima, please present a token of appreciation to Honorable Professor V.K. Paul, sir. Dr. Ankita to present a token of appreciation to Professor Randeep Guleria, sir. Dr. Priyanka to present the token of appreciation to Professor K.K. Roy, sir. Dr. Nimisha to present token of appreciation to Dr. Nalini Mahajan, ma'am. And Dr. Shivangi to present the token of appreciation to Professor Anita Singh, ma'am. Dr. Nimisha to present token of appreciation to Sabhita Gupta, ma'am. Saraswati Namastubhyam Varde Kamarupini Vidyarambham Karyami Siddhi Bhavatu Me Sada. No program can be successful without the blessings of Ma Saraswati. Hence, we seek blessings from Ma Saraswati with a Saraswati Vandana. I invite our esteemed guest for lamp lighting. I now invite Padam Shri Professor Randeep Guleria, sir, the guest of honor, to provide words of encouragement to the gathering. Sir is Director, AIIMS, New Delhi, Professor and Head, Department of Pulmonary Medicine and Sleep Disorders, AIIMS. He is the recipient of Padam Shri, the fourth highest civilian award in 2015, Dr. B.C. Roy Award for Eminent Medical Person 2017, and awarded the Doctor of Decade by IMA. Welcome, sir.
Thank you. Good morning. Professor V.K. Paul, Member Niti Aayog, Dr. Nalini Mahajan, Founder President of Fertility Preservation Society of India, Professor K.K. Roy, the Acting Head of the Department, Professor Anita Singh, my faculty colleagues, residents, delegates, ladies and gentlemen. I'm really delighted and very happy that the Department of Obstetrics and Gynecology, under the aegis of the Fertility Preservation Society of India and the IVF Research Societies, is holding this workshop and CME on challenges of fertility preservation in children and adolescent cancer as a part of an overall, let's say, workshop or training for life beyond cancer. I think this is a topic which is not discussed as much as it should be, but is becoming more and more important now with changes that have happened and advances that have happened. There have been major advances in the area of oncology. We've seen that, we've lived through that, from survival in childhood cancers in the 70s and 80s being around 40 to 45%, to, as was mentioned, survival now going beyond 80%, is a remarkable achievement. And this has happened because of newer drugs, chemotherapy being available, aggressive surgery being done. We have hematopoietic stem cell treatment available, radiotherapy available, including proton therapy, and now newer advances in the form of immunotherapy, which has opened up a new era as far as treatment is concerned. And then, of course, we have targeted therapy for certain cancers based on the mutation analysis that we do. So cancer, in many ways, has changed. And as was once mentioned, this is for lung cancer also, that from a disease with a poor prognosis and having really no survival, it's become more and more like a chronic illness, where you are actually able to provide longevity and survival to patients for a very long time. And that's true for many childhood cancers also. But when you start talking of all of this, then life beyond the cancer part becomes very, very important, because we're now talking of survival. And although for all of us as treating physicians and even for the parents, it's the initial part of getting over the cancer, getting cured of the cancer, that becomes the priority and the most important thing. But we forget the so-called late effects of the treatment that we're offering, And it becomes very important to be able to address how do we decrease the downstream sequelae that may happen. And I think one of them is loss of fertility. And that is what needs to be addressed because it's very, very important. And I'm glad that we're having this workshop on fertility preservation because, as was mentioned, this can really give these young children as they go into adulthood and family life good parenthood. A lot of new techniques are there. Dr. Anita Singh had mentioned that in the form of oocyte cryopreservation, ovarian tissue cryopreservation, sperm cryopreservation, and even testicular tissue cryopreservation. So there is a lot that is available. But I think the challenges here is awareness. Are physicians, especially oncologists and parents, actually aware of this, and are they properly counseled? So counseling, looking at emotional maturity, desire, fitness, all become very, very important. And as was also mentioned, the ethical issues at times. This is something that we need to address, and I'm sure this would be touched upon in this workshop. Patient selection, for that matter. Is the patient actually fit for the fertility preservation services that is being offered to him? What about the survival that the patient is likely to have? And also, of course, is the treatment that the patient getting warrant this procedure or not? Because now with newer treatment strategies, there are means that you could actually still be able to have fertility preservation without having with the chemotherapy or even the targeted therapy that is available. And therefore, I feel that it is time now for oncologists and fertility specialists to team up, to form a group and maybe have, as far as childhood cancers are concerned, a combined clinic. You probably would also need to have a counselor on board. And if a combined clinic where you have oncologist, fertility preservation specialist, a counselor, all available to counsel the parents, address these issues, discuss them, and be able to select patients who are ideal for this. There are various criteria. I'm aware that there's an Edinburgh selection criteria, which is available as far as this is concerned. So there are criteria which are available, but we need to look at it. How do they sort of fit into our own milieu? How do they look in as far as our own patients are concerned? And as was mentioned, we need to really have more awareness, develop more fertility preservation services, but they have to be in association with the oncologist and the treating physician. So a clinic or a teamwork is something that is required. I'm sure all of this would be discussed in this workshop, international workshop in CME. And I'd like to take this opportunity to once again congratulate the Department of Obstetrics and Gynecology for taking this step forward, especially Dr. Anita Singh, because this is something which gets neglected. And like I said, as we move forward towards life after cancer, this is something that we should not forget and address before we start the treatment, so that after cancer, there is a good quality of life. I wish you all the best. Thank you very much.
Thank you very much, sir, for your words of motivation. I now invite Dr. Nalini Mahajan, ma'am, to address the August gathering. Ma'am is the Clinical Director, NOVA IVI Fertility. She is the President, Fertility Society, Preservation Society of India. She is Secretary of Asian Society of Fertility Preservation, member of AOGD Oncology Committee, patron of PCOS Society of India, convener of Education Committee, Indian Fertility Society, and guide for fellows in reproductive medicine via IFS fellowships and NOVA IVI fellowships. Welcome, ma'am.
Good morning, friends and colleagues, the chief guest, Professor Paul, Professor Guleria, Professor Roy, and my very youngsters who are upcoming in this field. Today is a very proud day for me indeed. When I, in 2014, founded this society, we knocked on the doors of oncologists, but we were shunned away. People did not want to listen. And as Dr. Guleria just said, that the thoughts were, let these patients survive. What are you talking about fertility and fertility preservation? However, we persisted, and today we have reached a stage when the oncologists are actually in tune with us, in line with us, and they are referring patients for fertility preservation because they have realized that there is life beyond cancer, that patients survive, and then they're looking for a family. And today, I think I'm even more proud because Neeta has taken us one step forward into the area of adolescence and childhood fertility and fertility preservation, because this was an area which in fact is totally neglected in our country. And I don't really, I'm not surprised at that because, as was just said by Professor Rachna Seth, that our survival rates in childhood and adolescent cancer are much lower than in the West. And therefore, the priority, of course, is always oncology treatment. However, slowly and steadily, we will get there with better centers. We will be able to, provide these services to this group of patients. It is an extreme physical, emotional, and even a technical challenge to provide fertility preservation. But I think India is such an emerging medical force now in, all across. I think we are recognized as providing great medical services, and we want that in fertility preservation too. We should really be on par with the rest of the world. And with these few words, I once again congratulate Neeta and thank you, Professor Paul and Dr. Indeep, for being here and being so encouraging towards us. Thank you very much and welcome to this seminar.
Thank you, ma'am. I request Honorable Professor V.K. Paul, sir, the chief guest, to enlighten us with his words of wisdom. Sir served as the faculty at the Department of Pediatrics, AIIMS. Sir needs no introduction.
My home. It's my home. Thank you. Namaste. Good morning. Respected Professor Guleria, Director AIIMS. Respected Dr. Nalini Mahajanji, Dr. Roy, Dr. Anita Singh, my colleagues, Rachna, Tulika, all these distinguished colleagues from the faculty of AIIMS, residents, attendees, faculty from India, faculty from abroad for this important CME. I'm grateful to you, the organizers, for giving me an opportunity to be amongst you and to celebrate and compliment and to assist in a noble work, a cutting-edge new area of work for India. Very humane, focused, unmet need is what you are pursuing, and that really is remarkable. And I congratulate, I thank you, I compliment you. I would like to definitely say that your pioneering work, Dr. Nalini, that you took upon yourselves by creating Fertility Preservation Society of India is remarkable. And other champions who joined you, academics and non-academics, really very timely, you've taken this initiative. I'm also extremely proud of the work that the Department of Obstetrics and Gynecology of our institute has been doing for a long time in the space of reproductive health. There was a focus of a different kind where our institution was at the forefront in 70s, 80s and beyond. And we steered very important developments in the space of contraception, working very closely with global organizations, in particular the World Health Organization. So the legacy of that time is continuing. And of course, in our fold, we have that agenda of that aspect of reproduction and reproductive health, but also picking up on a very pioneering way, the other limb of the reproductive health and well-being, namely fertility, ensuring fertility, also has been done in a pioneering manner in our department, in our institute, and that I would like to bask in that glory along with all of us and all our leadership of our directors, Dr. Guleria, the current director, and so on. So very, very proud of the achievements of our Department of Obstetrics in multiple spaces, including and in particular, I would say, in the space of reproductive health and now in the space of fertility promotion, shall we say. As Dr. Guleria has very eloquently emphasized, the multi-dimensional considerations which are now taking us to life beyond survival. And they're focusing on preserving that aspect of life for children and adolescents is remarkable. It's truly remarkable. It's pushing the frontier where the frontier does belong. The cancer outcomes for children have improved. They are quite there now. The pediatric cancer community has really worked very hard in the last 2 decades to change the understanding, to change the outcomes, change the perception as well of picking up, diagnosing, treating cancers and giving a great life to children. And therefore, to push the frontier to children and adolescents for fertility protection, fertility preservation and protection is the right agenda to pursue. And in a very timely manner, taking lead, both the society and the institute. And we compliment you this morning for this. And we look forward to this movement to pick up. It's truly a teamwork. It cannot happen in isolation. And I'm sure in the larger affairs of the society, you will, for a cause like this, once you make this cause obvious and show hope, there will be champions, there will be advocates, there will be partners. And that, because it is fundamentally so humane a cause. In fact, I would believe that this should be, and why not, an integral part of our overall management of patients of all ages, wherever it is applicable, and even more so for children and adolescents, for 2 reasons: good outcomes and a long life ahead. Choices are still to be exercised by these citizens of our nation. And therefore, pushing the frontier is what excites me a hell of a lot today, this morning, that we are not accepting the status quo, we are taking it forward. It is the right of every patient, every child, every adolescent and their families to expect normal reproductive outcomes. I also noted the effort that you are making in the society as well as at the institutional level to advance the learnings to other centers. We compliment you on that. I would request you to obviously keep in mind the private sector as well, which provides an early uptake in a way. And why not? We should make sure that services are available on that side, even as we are pushing the frontiers in the space of public sector. In particular, the teaching institution, the centers of excellence, the medical colleges, and then going beyond that. I think we should have the whole vision set out that no child, no adolescent receiving cancer therapy and surviving should have to miss this integral part of human endeavor, human life, and human expectation and hope. Dr. Guleria referred to ethical aspects. I would be interested to know if there are issues around ethics for which guidelines may be needed at the policy level. I understand that the law takes care of most aspects. It gives you comfort, gives families the comfort, gives standardized, SOPs to follow, and there is a fear of punishment if these are not followed. But if there is any space that has been left out in this mission, please do let us know. We'll be happy to promote that. At the same time, I would also request you to kindly create increasing awareness across the sections of society. It's very important. I think we should raise that hope because that generates demand that pushes us to look at look at this option to be made available to everybody. Someday we would like to see it being linked to Pradhan Mantri Jan Arogya Yojana Ayushman Bharat. Why not? It's part of the package, part of the endeavor, part of life beyond survival. Why not? And how we do that would be something for us to explore. I'll be happy to work with you on that particular aspect. If there are other policy related issues, you may kindly bring it to fore. In order to increase awareness, this aspect should be touched upon in our education as well, because it should not be the last thing to think of. It should be known to the professionals of today who are going to treat adolescents and children and adults tomorrow, so that it is always something not to be forgotten, not to be taken for granted. And then you have a bigger family of professionals vouching for it, promoting it, and being part of the delivery teams, part of the team of providers. We are expanding the base for cancer care enormously in the country in the last few years. As you know, that with the involvement of Tata Cancer and the AIIMS network, huge expansion of cancer care, and more will follow. And therefore, it is time that we show it as an integral part, but also think about how this can be taken as an outreach system where the full-blown technology may not be there. So you come to the nitty-gritty, then it's not only about the intent, but it's also about the technology, the expertise. And the expertise you are building, but I'm also wondering whether you need help in terms of investments in the infrastructure in a certain tiered way in the public sector space. So do let us know if there are any ideas on this. But above all, it'll be a pleasure to be back home, to be in the company of distinguished colleagues, pioneers, and the community that looks after children, community that looks after cancer, community that looks after women and fertility. I'm very pleased to be here, and congratulations for this endeavor. Thank you. Jai.
Thank you, Honorable Sir, for the words of wisdom and motivation. I now request Professor K.K. Roy, sir, to render a vote of thanks. Sir is Professor and Unit Head and Chief Minimally Invasive Gynecological Surgery, Department of Obst and Gynae, AIIMS, New Delhi. Sir is a prolific researcher and has many awards to his credit, including the Lifetime Achievement Award by NARCHI 2016. Welcome, sir.
Respected Professor B.K. Paul, it happens to be that he was my guide, and I know his leadership and Professor Guleria, our Honorable Director, Dr. Anita Singh, Professor, and she has been the source of all this new technology. And in fact, the initiation of IVF, I remember in the institute, she worked very hard. Professor Nalini Mahajan, other dignitaries, students, ladies and gentlemen, very good morning. It is, I learned that the spectrum of these childhood cancers and adolescent cancers are huge. And the good news is that the prognosis after treatment is also almost 80%, though WHO says about 40%, but individual countries has different data. But this fertility preservations is a huge concern and throws many challenges. And, this conference is going to throw us more light on the preservations. I'm here to thank particularly our chief guest and Professor B.K. Paul, member of Niti Aayog, and you have seen his leadership during this COVID era. And we look forward that all health and policy decisions will be endorsed by him. And I must tell you that he will do the job once we approach him. I must thank Professor Randeep Guleria, our all these years, I have seen that with the support and leadership, that a multidisciplinary approach, now we are in an umbrella that every department has a stalwart for coordinations and, you know, a multidisciplinary approach and treating these adolescent cancers and giving them life beyond life. So I must thank you, sir. I thank you immensely for your support, and we look forward for all the supports possible. I thank Professor Nalini Mahajan. We know her for decades. When I was junior assistant, since that time I know her. And we are happy that, you know, you initiated this. And then it is now translated all over the country, not only in the institute, but all over the country. And we hope that, you know, we'll be doing much better job now, because institute is a platform where we can be a leader for others. I must thank each and everybody, because, you know, this is a CME program, and which is a very new thing, upcoming thing. And Professor Anita Singh, actually, you know, I know that she used to ring me up that I want to have a great success, because this is a very new upcoming. And I thank her, because she and her team really worked very hard day in and day out, and then made this CME a success. I will thank everybody, particularly the people who worked behind the screen to make this CME successful. I'm very sure it is going to be a very good academic fest. I thank all the dignitaries and the other students, particularly over here, that they will learn. Thank you very much.
Thank you, sir, for rendering the vote of thanks. With this, I conclude the inauguration ceremony and cordially invite everyone for tea. Thank you. Welcome back after tea break. We move on to the next very important session, the second session of the day, for which I invite an esteemed panel of chairpersons. Dr. Rishikesh Pai, sir. Sir is one of India's leading gynecologists and pioneer in ART. Dr. Pai has been trained in IVF by doing clinical fellowship in reproductive biology and embryology at the Royal Women's College, Melbourne, Australia. He did his master's in science at the Eastern Virginia Medical College, Norfolk, USA. He is the medical director of Bloom IVF Group. He has won many awards, including the Best Doctor Award by National Indian Medical Association, Lifetime Achievement Award bestowed by the Indian Society for Study in Reproduction, and Lifetime Achievement Award by the Indian Society for Assisted Reproduction. Sir had received the prestigious fellowship in the FRCOG, which was bestowed by the Royal College. I now introduce our second chairperson, Professor Tulika Seth, ma'am. Ma'am is the founding trustee and professor of hematology at the AIIMS, New Delhi. She is a clinical hemato-oncologist by training, having a distinguished academic career with over 160 research papers in various national and international journals of repute, over 80 index abstracts and 60 chapters in books, and she was elected Fellow of the National Academy of Medical Sciences in 2012. She harbors a keen interest in preventive medicine and public health. Welcome, ma'am. I now introduce Dr. Serene Kuman, ma'am. Ma'am has over 32 years of experience in infertility, IVF, and reproductive medicine. Presently, she's director and senior consultant IVF, Max Panchil. She was senior consultant in Safdarjung Hospital earlier. She's treasurer of Indian Fertility Society, editor of Indian Fertility Society Journal, chairperson, Infertility Committee, AOGD, 2018-20, and chairperson, Reproductive Endocrinology Committee, 2021-23. Our next chairperson is Dr. Jyoti Meena, ma'am. Ma'am is additional professor, Department of Obstetrics and Gynecology, AIIMS, New Delhi, with special interest in gynae oncology. Over to you.
Okay, so I'm very happy to introduce the speaker for this session, and the speaker is Dr. Rashmi Dalvi. She needs no introduction. She's a senior consultant of hematology oncology at the SRCC Children's Hospital in Mumbai, and she's an alumni of St. GS Medical College, KEM, and Wadia Hospital in Mumbai. And she's been trained in pediatric hemonc in India and in the US, and has been an awardee of the Hargobind Foundation of the UICC ICRETT fellowships. She's been involved in academics, clinical practice, and research, and has more than 30 years experience in this field. She's been holding many offices in the societies of the Pediatric Hematology Chapter of IAP, and currently she is the steering committee member of SIOP WHO GICC liaison. She's an honorary consultant for pediatric BMT and hemonc at the Lokman Tilak Municipal General Hospital and Medical College in Mumbai. And we invite her for this very important talk in fertility preservation in children.
Thank you, Dr. Tulika.
Just muted.
Oh, no, I'm not muted. I'm on. Can you hear me now?
Yeah, we can hear you.
Okay, I'm
Hear you?
sharing my screen now.
You stop sharing so that you can share the screen.
Right. Am I okay now to go? You can hear me?
Yeah, we can hear.
Right. So thank you, Dr. Tulika, for your introduction.
Ma'am, you are not audible.
No, but she is audible over here on the Zoom platform.
Yes, she is audible.
Audible.
My mute is off. So
Yeah, you are audible to us at least.
Yeah, you are audible.
Okay, should I go on?
Yes, Dr. Rashmi, you can go on.
Right. Also, thank you to
Perfect.
Dr. Anita Singh and the Fertility Preservation Society of India for inviting me to this very interesting symposium today. Right. So in my field of pediatric hematology oncology, we have fertility concerns in oncology in the realm of hemopoietic stem cell transplantation, and also in situations of where we need immunosuppressant therapy, because a lot of these cytotoxic agents are used as immunosuppressant or immunomodulatory therapy. It is estimated that about 70,000 new cases of childhood cancer will occur in India annually. And this represents about 4 to 5% of the total cancer burden in India. And adolescent and young adult cancers also represent 5.7% of cancers in India. And this is the population that we are talking about our fertility concerns today. This is an old graph, but I like to show it because as you can see that compared to adult cancers, childhood cancers globally do very well. And even if we have a little lower rates of outcome, it is not because the cancers are bad, but it is because of socioeconomic and other logistic reasons. But with this kind of improvement, this is 2009, and the graph is even will be even better today. But you can see that the number of survivors are only increasing, and it's estimated that 1 in 700 individuals will be a childhood cancer survivor soon. So this is the spectrum of cancers that we see. Dr. Rachna has already highlighted them, and most of them we use multimodal therapy, which includes, among other things, chemotherapy, surgery, and radiation. So these children and adolescents that we treat, they are vulnerable to impaired fertility due to cytotoxic agents. And this depends on various factors, including the age at treatment, whether pre-pubertal or post-pubertal, the gender, the treatment modality or modalities used, then the genetics of gonadotoxicity and gonadal reserves, the interruption of hypothalamo-pituitary gonadal axis, and other associated late effects like hypothyroidism and metabolic syndromes. So the treatment modalities affecting fertility, I'm putting this here because, as I said, that we use multimodal therapy, and even the cytotoxic effects of chemotherapy agents are in a milieu of many other treatments that are happening. So cytotoxic chemotherapy agents, radiation, especially gonadal, abdomen, pelvic, cranial, and craniospinal, surgery involving gonads or surgery involving the pelvis or even the spine, because it can affect the autonomic nerves or the vascular supply to the pelvic region. And CNS therapy or CNS disease affecting hypothalamus and pituitary area. Apart from this, cytotoxic agents are also used as I said, myeloablative therapy, used as high dose chemotherapy in relapsed or refractory disease. And then we have immunotherapy and novel therapies coming up, which also perhaps will have some effect on these. So which are the patients that we see at risk? Leukemias, lymphomas, Hodgkin's disease. Hodgkin's lymphoma is the quintessential example of fertility problems due to childhood cancer chemotherapy. Solid tumors, especially gonadal tumors, CNS tumors in the pituitary region or those requiring CNS radiation, and pelvic region tumors such as rhabdomyosarcoma, lymphomas, and bone tumors. So when we use cytotoxic chemotherapy, the basic principle is eradication of all cancer cells, and doing so before development of clinically evident metastatic disease. And as I've said multiple times, these are multi-drug regimes, and the drugs are used in a maximum tolerated dose to achieve efficacious kill, in spite of whatever toxicity they may cause. So, but this therapeutic dose also has an effect on the actively dividing host cells. Actively dividing cells are bone marrow cells as well as mucosal epithelial cells. And these result in acute toxicities, which we deal with. But some of them also have unique organ and tissue specific toxicities, which very often are cumulative. That is after multiple doses of the agent. And they are often delayed in onset. So these cytotoxic agents, they act at different time parts of the cell cycle. Some agents like the alkylating agents, they are non-cell cycle specific, and these are the ones which are most harmful to us as far as fertility goes. They cause damage to the DNA template. There's the intrastrand and interstrand cross-linkage, and results in impaired DNA synthesis and apoptosis of the cancer cells. And along with that, here in our area of concern, there's apoptosis of oocytes surrounding granulosa cells and early exhaustion of follicles. Likewise, apoptosis of spermatogonia and impaired spermatogenesis. And then there is a late effect of overall gonadal atrophy. In addition, these agents are also teratogenic and carcinogenic. So the most gonadotoxic agents of these are the alkylating agents. And the ones which give us very high risk are the first three that you can see here. The nitrogen mustard, cyclophosphamide, ifosfamide, melphalan. These are used in many various malignancies. Melphalan is used in stem cell transplantation. Nitrosoureas, which are used in CNS tumors, then busulfan again, which is used in CML, chronic myeloid leukemia, stem cell and transplantation. Then there are alkylating-like agents like heavy metals, platinum analogs, which we use quite a lot in many of our solid tumors, dacarbazine, temozolomide in brain tumors, and procarbazine, which previously was the number one culprit, one of the number one culprits in Hodgkin's, and we don't use it as much anymore. Right. So how do we assess the gonadotoxicity risk in a given patient? And there are various ways. So one was the alkylating agent dose score, which was brought in. And this actually takes the cumulative dose and plots it on a dose curve for a given cohort of patients. And based on the score that you get on the tertile, score of 3 and 4 is high risk for hypogonadism and fertility problems. However, this can be used only for a small population. So another one was devised by Dan Green and his team, and this was the cyclophosphamide equivalent dose, wherein they take into consideration, it's calculated by a formula. I haven't put it here, it's a complex formula, but easy to use. So this is the cyclophosphamide equivalent dose. And the risk criteria, the type of drugs that are used, the cumulative dose of these drugs, which goes into the formula, and associated radiation, as you can see. Ideally, this risk should be calculated pre-therapy so that you can plan and your fertility preservation or sparing, or from future point of view. So high risk are those who use high risk agents in a high risk dose. Those who get post-pubertal, Hodgkin's disease radiation and stem cell transplantation. Moderate risk are those with in the use of platinum analogs, atrimicin, patients who have a low AAD score or post-pubertal radiation, but in a lower dose. And then you have low risk, which are the anti-metabolite drugs, and low dose radiation, which is not in the pelvis or the abdomen. Now, gonadotoxicity in the male. Both the Sertoli cells and the Leydig cell are susceptible to chemotherapy-induced damage. The Leydig cells, they have a low mitotic index and are therefore less sensitive to radiation damage. And there is a dose-dependent decrease in spermatogenesis regardless of pubertal status at exposure. But a lower dose of these alkylating agents, you may have gonadotoxicity to begin with, but 70% of them have been shown to recover after several years of stopping treatment. Again, this problem came to light and was most important for Hodgkin's disease, where, as you can see, with the earlier protocols, 80 to 100% of male patients were azoospermic and often had permanent azoospermia, hypogonadism. Whereas with the current regime that we use, ABVD, the incidence is much lower, and there's almost up to 100% chance of, not always, but up to, it can go up to 100% chance of recovery. So another study has shown that the infertility among male survivors is around 46% in comparison to their normal siblings, where it is 17%. However, they showed that out of these 46%, 37% of those who were actually labeled as infertile had fathered one child with their partner. And these are the risk factors which talked about. So screening is important with an age-appropriate history, Tanner staging, and looking for gynecomastia, finding out sexual function, fertility history, hormonal evaluation peripubertal, and if it is not pubertal, then to repeat every 1 to 2 years, and so on. With respect to females, chemotherapy induces apoptosis of the primordial follicle pool, causes damage to the cortex, alters the blood flow, and ultimately causes ovarian atresia. In contrast to the male, here the germ cell failure and loss of endocrine function are synchronous. The risk factors, again, are dose and age-dependent toxicity. As was mentioned by Dr. Rachna, premature ovarian failure is what you see, and this can occur as acute ovarian failure during or soon after therapy, or may present as premature menopause under 40 years of age. And one of the studies of Hodgkin's showed that the risk with high-risk therapy, the actuarial risk of early menopause was 64% versus low risk treatment, where it was 15%. These children also have been, these individuals have been shown to have a 13-fold higher risk of infertility compared to their normal siblings. In addition, they may also have other health-related outcomes which may affect fertility, like osteoporosis, psychosexual dysfunction, hypothyroidism, and so on. These drugs are teratogenic during pregnancy, but it has been shown that there's no increased risk of childhood cancer to offspring of these individuals, except if it is a germline cancer predisposition syndrome related malignancy. Again, age-appropriate history, staging, and further evaluation as required. This is just an example that I have put up here, that this was a 10-year-old female who had abdominal B-cell NHL. This was in the 90s that we treated her with the COMP protocol. 15 years later, she relapsed and was treated elsewhere with chemotherapy CHOP. And at 22 years, again, she had some recurrent abdominal lymphadenopathy, suspected relapse, and she received 1 cycle of chemotherapy and rituximab, but some radiation and surgery, but she could not continue the chemotherapy because she had some very severe toxicity. However, she did well actually after that. She got married, she had a pregnancy, but she developed menopause at 34 years of age. She's now 38 years. She had multiple metabolic and other issues, but with various lifestyle changes, she is now fit and fine. This was another girl who was long ago treated in the 80s, and she was a 7-year-old female with Burkitt type of acute lymphoblastic leukemia. And as was the treatment in those days, she received this protocol with 3-year therapy, and it involved craniospinal irradiation. And this girl, I last saw her when she was 30 years old. She had severe short stature. She was amenorrheic, and she just looked like a child, even at that time. This is some of the Indian data. As Dr. Rachna Seth has mentioned, that for various reasons we do not. We now do have very formal after chemotherapy clinics and late effects clinics, but we have problems in that many patients actually do not follow up once the treatment is over, and so on and so forth. But we now have the Indian Pediatric Oncology group, which has a late effect study group. Dr. Rachna Seth is the chairperson of that group. And there are projects through this group. And some of the older data, I think Dr. Rachna has already shown, so I won't go into this, but these are from earlier patients, where we use the earlier Hodgkin's protocol with procarbazine and other things. I will just skip that. This is Dr. Rachna Seth's data, which she has already presented. And this is our data, which is more current. And these are children who were treated, a cohort of children over 10 years. And out of the females, all of them attained secondary sexual characteristics, but 3 with CNS tumors have delayed menarche. 2 of them are married with children. And among the males, most of them were above 11 years of age at the time of treatment. And they have attained secondary sexual characteristics. 3 are married, and 1 has proven fertility. So I kind of come to the end of my talk, and as you can see that endocrine, metabolic, and reproductive outcomes are all interlinked, and these children need surveillance. They need early identification for intervention from a fertility point of view. They also actually, we need to look at the fertility angle even, before completion, means at the time of diagnosis and starting therapy, and so these children and these issues actually need psychosocial support and counseling. From our point, from the oncology point of view, we need to refine treatment to minimize late effects, having more fertility friendly chemotherapy, fertility sparing surgery, radiotherapy elimination where possible, or refinement in radiation delivery techniques. There are many newer therapies for refractory and relapsed disease, and hence the profile of late effects and even reproductive effects is still evolving. Thank you.
Thank you, ma'am. It was a very lucid presentation, and you very beautifully highlighted the importance of counseling also, because in these patients who are undergoing chemotherapy, not only the effect is on fertility, but other aspects also. Like you very well said, that other health issues will also be there, like osteoporosis and psychosocial dysfunction. So it is very important that we carefully select the patients, and as you said, that we should use a chemotherapy friendly chemotherapy, fertility friendly or fertility sparing measures should be taken. But very important thing is counseling of these patients is very important before taking up for the treatment. Sir Paisa.
Hi, I'm here. Sorry. The Rashmi is my classmate, so is Madhuri Patil. We all from KM Hospital. And, in between, I had to zip through Bangladesh, give a talk and come back. So, but I only think this can be possible by digital, the way the speed is there. So I've been also doing a lot of preservation since 2007, oocyte freezing I started doing. And I do a lot of ovarian tissue freezing. So I think maybe the oncology groups in the country, because I've been struggling for I've done about 15 to 18 patients of cancer since the time I've done a huge amount of fertility preservation for lifestyle, but for cancer, I'm struggling. There are two consortiums, and I would like to request on this platform, Rashmi and all of you, that we need to have more connect. There is a Oncofertility Consortium in Europe, and there is another Fertility Protect Consortium in Europe and Oncofertility Consortium in United States. So we must have a consortium. We have huge amount of cancer in our country, and we must you have huge amount of cases for preservation of fertility. So how to do it? I would love to. Madhuri is also there, and all the Fertility Preservation Society, Dr. Majan, Dr. Anita Singh. We have to, Dr. Gopinath, we have to all decide on how to create that consortium in our country and now go to the next phase. We must say that by 1 year's time, we are going to cross 10,000 patients of fertility preservation. How do we do it? That is the role we need to discuss and focus on. Thank you.
Definitely. Actually, we have the Pediatric Hem-Onc Society in India, and we have an Indian Pediatric Oncology, study group. And actually, the late effects, Dr. Rachna Seth is the chair of that. So, we can, engage with, whoever and, get, look into that. Secondly, we also have an International Society of Pediatric Oncology, of which many of us are active members. So, there will be multiple ways of engaging, definitely.
Thank you.
And thank you, Rashmi. That was a wonderful talk. And there's just one question I had for you, that the score you put was very interesting, the AAD score.
Yeah.
In this, do you at some stage, maybe later or maybe with a family history, taken something about ovarian reserve or a family history of early menopause? Does that count in these?
Actually, no. Actually, these scores are basically for alkylating dose exposure only. Both the scores. So, but that is interesting to note. I mean, definitely, when we are taking the history, subsequently, when we are following up the patients, this could be one point.
That's very important, because any history of low ovarian reserve would definitely impact this score.
Yeah.
And the other question I had was that when you use ABVD instead of MOPS, there is no difference in the outcome of the cancer?
No.
So have you switched over to this regime with the younger children and the young adults?
Yes, more or less we have switched over to that. There are even other regimes, but ABVD works very well. And in fact, the same INPO group has a lot of studies that are coming out on the use of ABVD in our Indian children.
Okay, right, great. Thank you.
So thank you very much. That was an excellent talk and an excellent session. And the only other comment I just want to make is not only in late effects, but actually even in the counseling of cancer treatment, we often have families where they will abandon therapy because they are afraid that the girl will not be fertile. And if we have these kind of resources and we work together, which I think is really, really exciting, and the time has come for us to do this, I think it will help us to ensure that more patients will complete therapy because they know that they will have a wonderful life ahead. So thank you for the organizers for having this platform, and looking forward to interacting with the fertility preservation experts in our country. And it's wonderful to meet all of you. And as an oncologist, I really look forward to partnering with you in the future. Thank you so much.
Thank you, esteemed chairpersons and the speaker. It was a very enlightening lecture. We now move on to the next session, for which I would like to invite our esteemed panel of chairpersons, Dr. Sujata Kar. Ma'am is consultant gynae and obstetrics at Kar Clinic and IVF Center. She pursued advanced training in laparoscopic surgery from Calcutta and did her IVF training from Belgium and from London Harley Street Fertility Center. She is the recipient of many prestigious awards for her achievements in the field of gynecology. Dr. Seema Singhal, ma'am. Ma'am is additional professor, Department of Obstetrics and Gynecology, AIIMS, New Delhi, with special interest in gynae oncology. Dr. Atul Batra, Associate Professor, Department of Medical Oncology, All India Institute of Medical Sciences, New Delhi. And Dr. Shalini Kender, ma'am is additional professor, Department of Obstetrics and Gynecology, PG AIIMS, Chandigarh, India. Over to you.
Thank you, organizers, for inviting to this excellent conference. And the next talk is by Dr. Antoinette Anazado. So she's trained in pediatrics and adolescent oncology in the UK and completed her training with a clinical fellowship in Kids Cancer Center at the Sydney Children's Hospital. She was appointed as the Director of Adolescent and Young Adult Cancer at Sydney Children's and Prince of Wales Hospital in October 2010, and has subsequently developed a comprehensive AIIA cancer service across both the pediatric and adult cancer center. She has been part of the AIIA National Leadership Group, working with the national and state partners to develop specialist youth cancer services. And she also leads the Future Fertility Research Program on reproductive concern of cancer patients. She is the chair for the Australian AIIA Fertility Preservation Group and Guidelines Group. And she is the receiver of a number of awards. Few of them include Champions Award from Prince of Wales Hospital, Pride of Australia Award in 2015, and Churchill Fellowship in 2015. And she has recently won the Cancer Institute NSW Premiers Award, Rising Star and NSW Health People's Choice Award, as well as winning a Premiers Award in the Integrated Health category. So we invite Dr. Anazado for the next for talk.
Okay.
Her talk is about effect of non-cytotoxic and immunotherapy agents on infertility. So we look forward to hear you, Doctor.
Wonderful, thank you. So if you stop sharing, I'll share my screen.
Please stop sharing.
Please share your screen.
Sharing first from there. Then only
Stop from here. You can start sharing your screen, ma'am.
Ariane, stop, you cannot, she cannot share. You stop sharing from there.
We've already stopped sharing from here.
See over here.
Yeah, it has to go.
Yeah. Thank you.
Okay. Doesn't seem to want me to. Open. Sorry, I'm trying to share. It doesn't seem to want them. I'm just trying again.
Please select to share the screen.
Yes, I've done that, but it says to
You
open.
just select the share screen button and select your slide.
It says allow Zoom to share your screen, and when I do that, it says open systems preferences, but I did send my talk just in case there was an issue.
Excuse me, ma'am. Ma'am, you will have to share the screen because we cannot play from here. Then you will not have any, we will have to shift this PPT slides in. You will have to only play the slide.
Okay, I'm not sure why it won't let me.
We are sharing, ma'am. Just wait.
Yeah, ma'am. Meanwhile, we are trying to share the screen from here and we are trying to show the slides from here and then we can start.
Okay.
Yeah.
Ah, wonderful. Wonderful. So look, thank you for inviting me. I'm remember fondly coming to the conference before COVID, and hopefully we'll be able to come in person again. So today I'm really going to be talking about something that people may not have heard so much about. So we're talking about non-cytotoxic and immunotherapy drugs. And that's really important because there is a new field in oncology, which we call precision medicine, where we're looking at specific molecular targets for an individual patient's cancer and trying to target therapy for those patients. And this has been very successful in certain cancer types and increasingly is going to become a mainstay for cancer treatments, first in relapse and rare tumors, and then more and more in everyday tumors. And so why is this important? So Professor Dalvi has really highlighted very nicely the gonadotoxic risks of cancer treatments, so standard chemotherapy and radiotherapy. And we know that these treatments lead to temporary and permanent damage to gonadal tissue and gametes. Infertility causes substantial risks to patients, and those risks, as Professor Dalvi has said, is not just medical, but it's a psychosocial impact for the patient, their partners, and their family members. We are very fortunate to see an increase in cancer survivals. And as the speaker in the first session highlighted, childhood and adolescent cancer survivals is over 80% now. And so more and more, we are really trying to fine tune those cancers where the survival is poorer. And so there's a lot of patients who have rarer tumors where we haven't previously been able to treat them, or relapse tumors who have been overtreated. And so that's where the non-cytotoxics and immunotherapy drugs come in. And as of now, these are not drugs where there's a lot of reproductive data, but it's a very important group of drugs because while there are many gynecologists and fertility experts in the group, they will be seeing patients who not only have cancer, but they have rheumatological problems, they have GI problems, they have non-malignant hematological problems like myeloma, or they have neurological problems with things like refractory seizures. And these conditions are all now being treated with non-cytotoxics and immunotherapy. So it's actually broadening out the patient reach, not just cancer. I know this is a cancer conference, but a broader group of patients who up till now haven't really had the information about the risks of gonadotoxicity and the opportunities for fertility preservation. Next slide. Okay, so what are these drugs? So non-cytotoxic and immunotherapy, I've referred to them as NCIT. These are drugs where they have an interchangeable name. So they sometimes called molecular targeted drugs, precision medicine drugs, and these drugs are newer agents. They've got a slightly different mechanism to conventional cancer treatment, and they are enhancing the survival for cancer patients in several cancers. And the cancers that two cancers that people probably know most about where they're used is melanoma in the adolescent, young adult and adult population, where stage 3 and 4 melanoma 10 years ago would have been incurable, and now a cohort of these patients are surviving. And then in the childhood, very rarely, things like chronic myeloid leukemias being treated with tyrosine kinase inhibitors. Next slide. So this is a table based on Australian data. You'll see these are 9 cancers that are solely treated with novel agents. And it's very important to look at this cohort first, because this cohort of patients are going to give us information about the true risks of gonadotoxicity. These new agents are used in many, many more cancers, but they're usually used in combination as multimodality therapy. But in these 9 cancers, the non-cytotoxics and immunotherapy are used on their own. And that's why we're especially interested in this cohort, because it gives us information about the true risks on reproduction. So you'll see, as I've told you, melanoma, number 1, it's the most common cancer in the 15 to 45-year-old age groups in Australasia. They, again, have been treated by a number of different targeted agents with an increasing survival. GIST tumors, a type of a sarcoma seen in the young adults, being used, treated with tyrosine kinase, medullary thyroid cancers with specific tyrosine kinase inhibitors, and now the very selective RET inhibitor, selpercatinib, showing almost a 90% survival in these children with medullary thyroid cancer. So these are not only drugs that are specific for these patients, but we're seeing fabulous outcomes. And you'll see the others with similar targeted therapy. Next slide, please. So these drugs, in contrast to conventional chemotherapy and radiotherapy, they do not directly kill all cells. They're very specific. So they are tailored to specific molecular pathways, and that may be an effect on a specific molecule, on the surface of the molecule, or it might be a small molecule within a cell. And so when I explain this to patients, I think about a video game, Pac-Man. And Pac-Man, hopefully everyone in the audience is old enough to remember Pac-Man, where there is a circular type video game with a triangular mouth who's trying to eat things. And if you imagine that is the cancer cell, and the triangle is the specific target, okay? Now, if you can do molecular or precision medicine screening and you find out the target, that target may, like the Pac-Man, be on the surface. And if you find that target, it binds to the triangle and it immobilizes that cancer cell. So two things could happen. It either immobilizes the cancer cell so it stops producing and doesn't multiply. So the patient is living with their cancer. Okay, so as long as they take the medication, which for most of these drugs is oral, they will live a long period of time. And if you think about the chronic myeloid leukemia, there are now survivors who have been on these oral agents for coming up to 20 years. Okay. The other thing it could do is actually cause the cell, once it's immobilized, to start shriveling up and dying. And so in some of these cancers, we'll see that the effect, once the drug has had the effect, the patient can stop taking the drug. So thinking through that, we know that these drugs can induce cell apoptosis, they can inhibit angiogenesis, so cell growth, they can control the gene expression, they can trigger the immune system to start killing more of these cancer cells, or it can interfere with signal transduction. And so each type of molecular target, and there's a number of different types, has a different pathway and different mechanism of action. And the effect will depend on how long you're using these drugs. So one of the things we have to bear in mind as fertility specialists is, unlike conventional chemotherapy, we may get cures for these patients, or the patients may be taking the drugs for a long period of time, rendering them chronic cancer patients. But the fertility effects you may not see straight away, and slowly over time, because they're continuing to take these drugs, the patients start having problems with their ovarian or testicular reserve. Next slide. So how do we gather evidence for reporting on gonadotoxicity? Well, you'll see internationally, neither the FDA, so the Food and Drug Administration, or the TGA, the Therapeutic Goods Administration, mandates that we have to provide human or even basic animal toxicity data on approved product informations. Okay, so we, as my research group, have looked at the non-cytotoxic and immunotherapy drugs over the last couple of years, and we found that, you know, very few of them have comprehensive information on or acknowledging the reproductive risks of these drugs. Okay, and it's the paucity of data that actually hinders us. It hinders the oncologists or other specialists in actually realizing there's a risk. It hinders them in making the referral to the specialist, fertility preservation specialist. And it also hinders us being able to make a recommendation for fertility preservation. So the truth is, without this information, we don't know whether we are treating too few patients, or we're over-treating and doing fertility preservation on patients who may actually not need it. And that, when you think about resources, is also very, very important, because you don't want to over-treat patients when this is actually an expensive procedure to do. And then there's, as Professor Dalvi has said, the psychosocial implications for undergoing fertility preservation and not knowing whether you're going to be infertile. Next slide, please. So again, so my research group, about 3 years ago, we started investigating this area. And the first thing we did was we reviewed the 32 non-cytotoxics and immunotherapy that had been listed by the FDA and TGA over a 5-year period. So of the 32 drugs, none of these drugs had any human data on the reproductive effects published or in the unpublished proprietary data, okay? And what is usually the fallback is in the patient information sheets or the clinical trial informations, they say, please advise the patient to use contraception or consider fertility preservation, okay? But that recommendation is not based on the evidence of risk, okay? So from preclinical data, 23 of the 32 drugs had some preclinical data. only 2 of those 23 reported no adverse experimental effects on gonadotoxicity. 9 had inconclusive data. 9 in males showed infertility, and 3 showed infertility in the females. So certainly the preclinical data that exists is enough for us to start worrying that the influence of precision medicine that we are about to see increase exponentially in our clinical practice may actually become a new risk for cancer patients. Next slide. So what human data is available? Well, sadly, the human data is very sparse and quite disappointing when you think that there have been more common tumor types like melanoma, like chronic myeloid leukemia, which now have over a 10 to 20 year period got actually extensive, certainly treatment data. But it's because fertility, when you've got a cancer which is not curable, people don't think about fertility. It's only when you suddenly realize over years that more and more of these patients are surviving and that the cancers are in younger patients who actually haven't started or completed their families, that it becomes something that people are interested in documenting. And so you'll see with the immune checkpoint inhibitors, these are very commonly used for melanoma. There's only 4 reports of pregnancy after treatment. I find it hard to believe that that is the case, but again, that's what the data says. There's a case report of 2 men who treated for melanoma with immune checkpoint inhibitors, one on a drug called vemurafenib, and they had minimal effects on sperm output, but the other on dabrafenib. And in this male patient, that had more detrimental impacts on sperm output. So again, this is someone who's documented it in 2 patients, and you can see we've got contrasting information. There is one paper which is a post-mortem paper, and it is very interesting on spermatogenesis. They have 7 patients who have been treated with immune checkpoint inhibitors, and they show that there is definitely detrimental effects on sperm output in these patients. However, these patients, are dying, have died, and during that time, we know that there are other terminal effects in those patients' bodies. So it's hard to completely say that all of the effects on spermatogenesis were due to the immune checkpoint inhibitors. The last area was the tyrosine kinase inhibitors. And again, tyrosine kinase inhibitors have been around for a long time. You saw in the table previously, nearly all of the 9 cancers solely treated with immune therapy or non-cytotoxics have used a tyrosine kinase in some way. And what we know about the data available is that in male patients, in the developing gonads, it seems to have an effect, but in adult patients, the effect doesn't seem to be as marked. Next slide, please. So in our center, again, moving on to this, we wanted to see, well, what is our experience with these non-cytotoxics and novel agents, and is it enough for us to make any recommendations? So for the females, looking through, this is retrospectively, looking through the notes, and because our patients get evaluated and we have a registry, we're able to pull those data. We had 7 patients, and they were aged between 18 and 37 on a number of different drugs. And 6 of those 7 female patients continued to have regular menses all the way through their treatment. The evidence of ovarian toxicity is manifested in the reduction in the antral follicle count, with a median antral follicle count of 14, a range of 7 to 50, and the serum AIIMS median of 12 on the 10th percentile. But there was inconsistent patterns in the serum LH, FSH, and estradiol. And the difficulty with these 7 patients, of course, it's only a small number, but there are so many different categories of non-cytotoxics and immunotherapy that to get very clear data, we're going to have power in each type. So your tyrosine kinase inhibitors, your ALK inhibitors, your MET inhibitors, we're going to have patients in each of those types. Next slide, please. So in terms of pilot data for males, we had 14 patients aged between 19 and 42, mainly with melanoma. 10 of them had melanoma, others with tyrosine kinase inhibitors. And because we have a lot of males who come in for sperm banking, we're able to have matched controls as well. And in these 14 patients, we actually did not see significant adverse impacts on any of the semen variables or reproductive hormones that we had. Next slide. So what is the relevance and importance? Well, I think I have clearly articulated that we are increasingly going to be using these drugs as curative treatment protocols. And while the 9 cancers I've highlighted are cancers of slightly older patients, and some of those patients may have completed their family, we are using non-cytotoxic and immunotherapy in pediatric protocols as part of combinations. And so while these drugs promise less gonadotoxicity damage than conventional cancer treatment, there is a lack of data, and it is really important for us to start thinking as a community, how do we answer that question? Next slide, please. So we have opened last year the first study on non-cytotoxic and immunotherapy, and the aim and objectives of the study was to determine the impact of novel non-cytotoxic cancer treatment on the fertility in male and female cancer patients, and to initiate follow-up of fertility amongst patients who'd had this treatment. Next slide, please. So the study has 2 cohorts. It has cohort 1, which is a longitudinal study of male and female patients who have been treated with these drugs. So we appreciate that it's going to be very important to quickly get data on patients who have had these drugs. And we also know it's going to be complicated because the patients we really want to highlight are those that have not had conventional chemotherapy or radiotherapy. So the data is clean. So we have the longitudinal study, not because it's an ideal study design, but it's a way of allowing us very quickly to see whether there's any problems, and then say, well, of all the different types of non-cytotoxic immunotherapy categories, can we pick out some categories to specific look at? So is it all of these drugs, or is it just specific ones? And then cohort 2 is really how you should design the study. So it's a cross-sectional study where we look at patients prior to starting their cancer treatment, and then we follow them up. And like I said, a lot of the patients who are on non-cytotoxic treatment will have the treatment for a long time. So what we need to find out is whether it is a dose effect and what that cumulative dose effect will be. Okay, so for these patients, we certainly want to start with getting a sample of 100 and hope to have 20 in each of the common non-cytotoxic and immunotherapy categories. And also, we've got to think about the gender issues and make sure that we look at both male and female patients and think about the effects of age. Next slide, please. So to start with, our ethics group would not give us permission to do this study in children. They felt that it potentially was going to be causing more distress to families to think that there were unknown risks than actually helping families to make decisions. And they felt that it was ethically better to just do the study in basically patients who are aged from 18. The patients have to consent to blood tests, ultrasound scans for if they're females, semen analysis if they're males, and to allow us to monitor them before and in 3-month intervals for those patients who continue on the non-cytotoxic agents. Next slide. So this is really what I've said before. Reproductive and general medical history is really important. I think over time we'll find, as part of the risk that Professor Dalvi spoke about in the last slides, we'll also find the actual genetic risk of infertility that plays a part in the gonadotoxicity profile of patients. For the male patients, we obviously want the testicular volume, we want reproductive hormones for male and female patients, semen analysis, and in our center, because we do fertility preservation, we give them the opportunities to have fertility preservation, knowing that some of these patients in the future may actually not need it. So we just don't know. And we're taking the opportunity to look and collect DNA blood tests so that if we identify specific genes that influence reproductive damage, we can do some more tests. So I think you'll see from this, this short presentation that while non-cytotoxic and immunotherapy agents are increasingly more common in cancer treatment, we have a long way to go before we get more generalizable gonadotoxic information that will be useful. But I think if we start thinking about it now, we'll be able to give really useful information to patients in a short period of time. So I thank you for listening to my talk. I'm happy to share the papers and the publications with the study chair, and very happy to take any questions. I think I've gone through that slide. So
yeah. Thank you, ma'am. Thank you for such a comprehensive talk and sharing your experience with us. And now I think we all can counsel our patients. We can reassure them who are taking these drugs, you know, and this topic is such novel topic. We have never read this topic. And so we are really reassured that these patients, the effect is not much on their fertility, and, you know, we can reassure them.
We hope.
So do we have any questions in the chat box?
Yeah, Dr. Anazado, I'm Dr. Shalini from... Yeah, actually, you've covered everything, and what we can conclude now that we still are actually lacking any robust, effect of these drugs on the gonads. So when we are talking about the counseling of our patients, especially in our setup, we need to at least inform when we are going to give this to the young adolescent or the reproductive age group, that we do not actually have any backing of information, what effect it will cause. So the consent taking becomes very important when we are going to start these drugs. And especially with the study you quoted, which was including 23 studies, only 2 studies said that there was no effect on the gonads. Rest, 9 were inconclusive and 9 had impact. So, we are nowhere still.
This is so true. Look, it just goes to show when drug companies are putting things together, when our clinical academics are putting studies together, they're not always thinking about survivorship. They're not thinking about the future. Yeah, exactly. They're thinking about cure. And remember, a lot of drugs now for precision medicine are being repurposed. So for example, this week I started a 13-year-old boy with T-cell lymphoma, relapsed and refractory, on a breast cancer drug based on the molecular profiling we got, okay? So if the drug hasn't been tested for males, this is a drug that's being used a lot for females, we've got nothing on the males. And more our practice is getting like that. So we've got this double-edged sword. We want to provide information for patients. we want to do fertility preservation, but we don't want to worry people by doing it too much. And we don't want them to have the burden of cost of doing an unnecessary procedure. And then we've got the added insult, which is if the patients have molecular screening and the drug is tested and works clinically, they may be on this drug for years. So with the CML patients, we used to transplant all these patients, and now we've realized they can be on imatinib, dasatinib for years and years and years and live just normal life with taking 1 tablet a day. But they're going to be taking these tablets for life. So more and more we're seeing young men with tyrosine kinase inhibitors whose sperm quality is poor. So it's very important that we start collecting the data to give some reassurance.
And another thing we recently discussed with the onco people, who were treating breast cancer was the way you reported that the hormonal profile is very variable. So we realized when we were giving them therapy for breast cancer, the FSH level would rise. And then the FSH level came down, which is not the routine we see in other reproductive women. So, this is something very different, which happens in the oncology treatment.
That's right. That's right.
Thank you.
So with the permission of organizers, can we close this session now? Thank you so much, organizers, for giving this opportunity. Thank you.
Thank you, esteemed speaker and the chairpersons. It was a wonderful session. We now move on to the next session. For this, I invite a panel of esteemed chairpersons. Professor Leena Wadhwa, ma'am is professor at ESI PGIMR, Basaidarapur, Delhi. Dr. Nivya Walicha, consultant in charge, Fortis Ridge IVF, Shalimar Bagh. Dr. Navdeep Kaur Ghuman, ma'am is associate professor, obstetrics and gynecology, AIIMS, Jodhpur. And Dr. Latika Chawla, associate professor, Department of Obstetrics and Gynecology, AIIMS, Rishikesh. I request Professor Leena Wadhwa, ma'am, to introduce our speaker.
Am I audible?
Yes, ma'am, you are.
Yeah. Thank you for the kind words. I take the privilege and honor to invite Mr. Surendra Viraya. He has a lot of experience, 20 years of experience in the field of psycho-oncology. Professor V. Sundaran is currently heading the Department of Psycho-Oncology and Resource Center for Tobacco Control at Cancer Institute, Adyar, Chennai, India. He has published more than 20 scientific articles and has contributed various chapters. And to his credit, he has initiated various patient support group programs and designed interventional modules to improve them. And one of the highly appreciated initiatives is the free WIC program for patients receiving chemotherapy and offering breast prosthesis for patients underwent mastectomy. He is one of the expert members of the State Policy for Cancer Care, Government of Tamil Nadu. Also serves as the chairman of the Independent Ethical Committee of Psychology Division, Women's Christian College, Chennai. And he will be speaking on the psychosocial dimensions of cancer in adolescents and children. Dr. Surendra, please.
Thank you, ma'am. Good morning, everyone. I think good afternoon. Am I audible to everyone?
Yes, you're audible.
Thank you. Is my PPT visible to all of you?
Yes, it is visible. You can go ahead.
Right.
You can make it full screen.
I've done it, so I'll do that again.
Yeah, it's visible.
It's okay, right. So at the outset, I would like to thank the chair, Dr. Anita Singh, and all the organizing members and beloved colleagues from the oncology area. Thank you for the opportunity. First of all, my sincere appreciation to the organizing team for thinking about including this topic. Generally, this topic is ignored in many of the meetings, I would say. But this is something that's very important. And I was listening to all the lectures and everybody pointed out that this is something which is very essential and need to be included, especially in pediatric and the children with cancer, not only during the treatment, even post-treatment during the survival. So to start with, generally the cancer diagnosis itself leads to distress, not only to the patient, also to the family, siblings. To add one more point, this is very distressing for the treating physician and the entire healthcare providing team, because it's very disheartening at most of the situations when the child goes through procedure. The doctor really need to convince the family and ensure that the child receives the treatment, even the evaluation. The procedures are done on time and the child is put on treatment on time. So all these are very challenging for the treating team, especially the physician, because we see that on a regular basis, whether it's surgery, radiation or chemotherapy, but it's very distressing for all of them. So so the distress, not only in diagnosis, whenever the doctor need to talk about the outcome of the treatment, whether it is remission or whatever it is, the decision need to be communicated. And then the family has to take a decision what is next. So everything is very challenging. So the communication plays a vital role here. And most of the time we are involved in that process where when the family and the patient goes through the distress, and we spend, and now we have a dedicated team of staff who offer intervention, the behavioral intervention in reducing the distress. And not only during the treatment, now with the help of the Indian Cancer Society, we started after completion treatment therapy clinic, where we have a dedicated psycho-oncologist along with the doctor. They assess the psychosocial aspects of survivorship, and that's also being documented, and wherever required, appropriate interventions are offered. And if there are recurrence, special attention given. Now we have a dedicated pediatric palliative care unit dealt by our palliative care team. So why I have this slide as a first slide. So when we say it's a teamwork, it is definitely a teamwork where everyone needs to be involved. So now I'll take you through other specific issues that a child and the family goes through during the treatment and post-treatment. So distress associated with medical procedures, as you all know, and doctors like Balvi and the doctor beautifully explained about the treatment and the procedures and the toxic effects of the treatment. See, generally, one side is the effect of treatment. The other side is the child, when the child goes through procedure. For just to take one procedure, bone marrow aspiration, though there are advancements, it's made painless procedure, but still that reminder is always there for a child. Whenever you talk, when the child is asked to go for a BMA second time, the child definitely goes through distress. So so definitely in cancer setting, especially in pediatrics and adolescents, this invasive cancer diagnostic and treatment procedures are always a reminders resulting in distress. And the children with lower levels of attention have more difficulty. Of course, you encounter a child with different levels of intellectual functioning, and accordingly, you may encounter issues and concerns. So experiencing distress during procedures, long-term treatment-related anxieties are very common, and these sequels may occur before, during, even week after the procedure. But the important thing here is to identify those problems and address it on time, so that you can prevent from a child developing severe consequences, especially the psychosocial consequences. So younger children exhibit more distress because they are, they will be having, generally the young children will have a lot of issues when they go to school, when they move to other social situations. So here the same. So the trouble is more when they are very young. So because they may have frightening fantasies, and parents feel helpless and guilty as they watch the child suffer. Most of the time, the counseling and the behavioral intervention is required for the parents than the children. And as I told you earlier, it is not only for the parents and also stressful for the medical staff, especially for the doctors. And we often discuss about de-stressing oneself from all these ruminating thoughts. Now, coming to specific issues, see, this is one of the common problem that is encountered by the treating physician, that's the non-compliance to treatment. It is really an impediment to therapy administration. Not only therapy administration, it also affects follow-up, going for evaluation. When we talk about treatment adherence, so it really affects. So refusal of a treatment, failure to keep an appointment, choice of alternative treatment modality. Sometimes what happens, they also think about going to alternative treatment. That is where talking to the family and explaining them the importance of continuing treatment and understanding their concerns and issues associated with involving in this procedure is very vital. What we did here in our institute is we have, because every time considering the load, so it's very difficult for us to sit with a child for a longer time. So what we have done, we have developed a module, interventional module, where the doctor explains the procedure, whatever the procedures may be, in different languages, in all regional languages. And we have a leaflet containing the messages, and we show it to the child as well as to the mother or the caregiver, care provider, immediate care provider. And following that, we will have a one-on-one session. And if they have further concern, then we will address that so that the compliance improves. And the non-adherence in our institute initially was very high. Now it has drastically come down because of this procedure. So if you look at the data, so the non-compliance rate is under the age of 13 years is 33%. And in adolescents, it is 59%. See, non-compliance in adolescents is high because of the other psychosocial concerns, I would say. See, there are, when I say other psychosocial concerns, it's especially the anticipatory nausea, vomiting that I would generally relate with, especially adolescents, and also other surgical procedures. For example, if there is a loss of limb, that can be one of the important aspects that you need to pay attention to. And common psychological comorbidities are adjustment disorders, neurodevelopmental disorders, depression, anxiety. When we talk about anxiety, it is procedural anxiety and separation anxiety. These are commonly reported. And earlier I was talking to you about the anticipatory symptoms. 29% develop anticipatory nausea and 20% develop anticipatory vomiting. And of course, it may be not maybe, it is definitely distressing for a child who goes through this whenever they think about a procedure, or whenever they think about the follow-up, or when they think about the next chemo cycle. It is very disheartening for a child. So if you prepare a child and the family member, and the procedure goes through easily, if not in all cases, at least in most of the cases. And psychiatric emergencies, this is something I think all of us need to be very much aware of. There are occasions where the child may have suicidal thoughts, or may attempt, or self-harming behavior can be seen in children especially, and adolescents especially. It's very high, and the suicidal rate also very high in that age group, above 15 years, I would say. So we need to pay attention. So we have made the distress screening as a routine procedure in all our pediatric unit, and so we follow them up closely if the distress score is more than 4. And delirium also noted commonly among children receiving chemotherapy. I think this is something that pay attention, where you need to have a proper differential diagnosis and refer the patient to a psychiatrist if required. And when a child is very aggressive or potentially dangerous to others, and we should educate the staff nurses or the treating physician involved, and alert the family and offer intervention on time to avoid other damages or other issues. And very pertinent and important aspect, I thought this is something very important to discuss, which meaningful in this meeting. Fertility and sexuality, of course, all of us are happy. The good news is that there is an increased number of survival. And if you look at the previous speakers beautifully explained about the survival. But I'm very happy that in, I think, lower income countries, lower and middle income countries, India stands very high with respect to pediatric cancer survival. I think we are showing, we have the result of more than 60% of survivorship among pediatric cancers. So what happens is when we see one side happiness, the other side is there are toxic effects which need to be paid attention. And I think if we pay attention to this, I think the future, these children will have good quality of life during their survival. So this, I think the Dr. Dalvi has already explained about this. The infertility was observed in 46% of the survivors, especially males, versus the 17.5% of the siblings. The general population, it is only 17.5%, whereas it is 46 in the cancer survivors who treated a very young age. So the psychosocial factors are playing a very significant role in development of sexual problems in children. So early age at diagnosis is one of the important factors that we need to look into, and because which may negatively influence sexual identity formation and consequently longer term psychosocial sexual development. So see why we talk, see, for example, this is a transition from adolescent to adult, the child, adolescent, adult. If you take the child above the age of 12 years to 18 years, this is a complete transition. So that's when they receive these chemo drugs, which the doctors were talking earlier, definitely it has its adverse effect. Definitely it affects the growth as well. So where they have the identity crisis and they have their own doubts about, who am I? And am I look like a normal person? So this is where we need to pay attention. So you need to prepare the child, give them reassurance and help them understand that there is a life after this. So that is something very important. And you all were, Dr. Pai was talking about, I think, fertility preservation, wherever there is a possibility. And we should, of course, the researches are very scarce, and I think we have not paid much attention in the past. Good that we are talking about it now. I think future, definitely there will be trials coming up, and there more meaningful outcomes can be seen in the near future, so that it will improve their self-esteem and improve interpersonal understanding post-treatment when we pay attention to fertility and sexuality. And sexual dysfunction is also commonly seen among the survivors, especially this is more common among women gender during their survivorship. So difficulty in sexual functioning reported in around 43% of young adult survivors of childhood cancer. And this is due to, this may be due to the treatment, physical symptoms, psychological factors, and social and interpersonal factors. So that's why, of course, you all know, you may pay attention to the physical and treatment factors, but I think it's very important to closely look at the psychological and the social and interpersonal factors associated with this component. Many times in our, if you look at our culture, even parents fail to talk about the sexual functioning and even reproductive and fertility issues because they are hesitant to talk to the doctor. Sometimes the family asks them about, doctor, can my child get married? And if married, will my child become a father or mother? These are all the greater concern when they come for follow-up. May not be at the time of treatment, but definitely during the follow-up. At the time of treatment, their concern may be more of helping the child live, making the child live. They talk more about survival there. But when they come for follow-up, they're concerned mostly about academics, mostly about the reproductive and the fertility related issues and marital concerns. And I just quickly go through this, and even my doctoral dissertation was on this. See, definitely these drugs, especially radiation and chemo drugs, some of the chemo drugs are associated with neurocognitive deficits. And now there are newer protocol which are showing very less neurocognitive deficit, but we are yet to see a trial with no deficit. So this I spoke to you, and other issues are like agitation and behavioral difficulties, and these are commonly seen when the child is receiving treatment. And social adjustment, also one of the commonest problem experienced or encountered by children when they go back home, when they continue to school and job, so during their survival. So social difficulties may also arise secondary to separation from peers as a result of hospitalization, isolation at home, limitation in activities imposed by their disease. So these are some of the other concerns. And the other concerns which I would like to touch upon is the post-traumatic stress disorder. I don't say disorder, the symptoms. We need to look at the symptoms when the child comes to your ACT clinic. Be very, very important. And academic problems, of course, definitely these children go through academic problems. It is increased risk is seen when they are diagnosed at a very young age, and prolonged school absence and cancer treatment that result in a reduced energy levels, cancer treatment affecting hear and vision. Not all children, sometimes it happens, cancer treatment resulting in physical disabilities. And as I told you, sometimes when the child is supposed to go for amputation, then that though there are improvement and innovations in surgical procedures, but in some cases it is unavoidable. They had to go for it. In such situation, you need to really prepare the child to cope and reassure the other possibilities, especially rehabilitative procedures. And what are the, I've come to an end. So now, what are the predictors of positive family adaptation? So these are some of the predictors of positive family adaptation: absence of premorbid psychopathology, and if there are no psychiatric or psychomorbidity in a child, I think that is one of the family factor associated with positive family adaptation. And family cohesion and flexibility. This is where when a doctor or a team works with a child, you need to involve the family, especially siblings in this case, I would say. Ability to recognize and balance demands of the illness with the family, and access to economic resources. That is something very important that we need to pay attention. Clear family boundaries and open and effective communication is much needed. Otherwise, they'll come back and question you. You said this, but see, now it is reverse. Please explain. So our communication should be very, very clear, and active coping. Teach them. There are different ways of coping, adaptive, maladaptive, but teach them actively how the child can be engaged during the time of treatment and during survival. And a strong spiritual belief system. When there is a spiritual belief system, then definitely one of the good adaptation that helps family adopt very well. And social support is another important aspect that we all should pay attention to. So overall, I would say when it comes to children and adolescents, psychosocial factors definitely plays a vital role in improving the quality of life if we pay close attention and offer intervention at the right time. When I say right time, from diagnosis to survival, even if it is end-of-life care, and I think we need to discuss and disclose the information appropriately using the right strategy. That will definitely enhance the quality of life, but not only quality of life, the quality of relationship with the physician, family, and the patient. Once again, I take this opportunity to thank the organizers. Thank you so much. Look forward to questions.
Dr. Latika, you can take over.
Thank you so much. It was a wonderful talk, sir. And considering we come from a system that usually takes a backseat, Even discussions on mental health and mental support are considered to be a taboo here in our setup. So I think this was a fantastic, issue that needed to be discussed. Even for adults, we don't talk about mental health, let alone for small children and adolescents. So I congratulate you on your talk, sir.
Thank you so much. Thank you. Thank you.
I think if there are no questions in the chat box, we can close this session. Okay, I would like to thank Dr. Anita Singh and Fertility Preservation team for this arranging this wonderful CME. And with this, I close this session and we move for the next session. Thank you.
Thank you so much.
Thank you, esteemed chairpersons and the speaker, for this enlightening session.
Thank you.
I would like to extend a very warm welcome to our distinguished guest, Dr. Kavita Rajashekhar ma'am. Ma'am is Senior Scientist at the Department of Health Research, Ministry of Health and Family Welfare, Government of India. Ma'am could not be there for inauguration, but has now graced the occasion. I request Dr. Ankita and Dr. Shivangi to extend floral welcome and token of appreciation to Dr. Kavita ma'am.
Please switch on light, please.
Tanya, you gave.
We move on to the next session. For this, I'd like to invite our chairpersons, Professor Anita Singh ma'am. Ma'am is Professor, Department of Obstetrics and Gynecology at AIIMS, New Delhi. Professor Mohan Kamat sir. Sir is Professor and Head, Department of Reproductive Medicine, CMC, Vellore. Dr. Umesh Jindal sir. Sir is the Project Director of the Jindal IVF and Sant Memorial Nursing Home. And Dr. Papa Desari sir, Senior Professor ART Coordinator at JIPMER. And he has delivered the first ICSI baby of JIPMER in 2020. Over to you, ma'am.
Okay, so a very warm welcome to Dr. Madhuri Patil, a very good friend and a very vibrant person I know in this fraternity. She's a very famous and renowned reproductive endocrinologist and infertility specialist, and she is the president-elect and founder member of our society, which is called Fertility Preservation Society of India. She's been the vice president of PCOS Society, and she's on the executive board member of Asian Society for Fertility Preservation. And she has many awards to her credit. Let's not come into her talk and listen to her what she's going to talk. We are already running late of the schedule. I'm really sorry about this delay in the program, but we are all waiting to hear Dr. Madhuri Patil.
Thank you, Nita, for that introduction. And also I congratulate you on having this program. And I think it has been a great program. And I would be talking today on the different techniques of fertility preservation in prepubertal and adolescent patients. So we are aware that we require fertility preservation in childhood and adolescent cancers because we've already heard Dr. Rachna as well as Rashmi talking about the effect of chemo and radiotherapy on future fertility. And probably we have to look into those individuals whose previous treatment of childhood cancer has also led to infertility or stability and can often benefit from fertility treatment options such as egg and sperm donation, gestational surrogacy, and other still experimental procedures. We've also seen that there is an improvement in the survival in these children who have had cancers, or especially those under the year of 14 years. And it is almost about 83.8%, that is, we can say about 84%, and 1 in 1,000 adult is a survivor of childhood cancer. We've also seen the various cancers which are common in childhood, and I would not like to go over it again. And I would like to talk about those conditions, especially which require counseling about fertility preservation. And when we talk about the female children, especially those who have been subjected to high dose of alkylating agents like cyclophosphamide, and here the is about 1,000 to 2,000 in a female, whereas that in the male is about Then we have those patients who have been subjected to radiotherapy. The female, both the ovaries and uterus can be involved, whereas in the male, it is basically the testes. Those having cranial irradiation as well as a hemopoietic stem cell transfer, and those for who have been subjected to oophorectomy in the female and orchidectomy in the male for cancer involving the organ. We've also looked at the various risks associated with chemotherapy. So we have those which have a high risk of infertility, which includes cyclophosphamide, ifosfamide, mulistin, busulfan, melphan, procarbazine, chlorambucil, lomestin, and metoclopramide. Whereas those with medium risk are cisplatinum, carboplatinum, and adriamycin, and all these other drugs like vincristine, methotrexate, actinomycin, bleomycin, and vinblastine have a very low risk to fertility. If you look at the impact of radiotherapy and chemotherapy on female fertility, the chemotherapy can have direct ovarian toxicity, vascular toxicity, as well as cellular effects, which can affect the cytoskeleton, the DNA, and oxidative stress. But radiotherapy will affect not only the ovaries, but also the uterus. Whereas in the male, if you see in this picture, we can see that there could be damage to the spermatogonial stem cells with permanent azoospermia. There could be damage to differentiating germ cells with transient azoospermia. And there could also be damage to the Sertoli cells, wherein you can either have a transient or a permanent azoospermia. And there could be damage to Leydig cells, which occurs only at very high doses and is generally not seen. And this can then lead to testosterone deficiency. Whether we go in for a fertility preservation procedure or not will basically depend on certain factors, both in the girls as well as boys. And these include the intrinsic factors like the health status of the patient, the psychological factors, and the consent, which has not only to be obtained from the patient, but also from the parents, because they are under the age of 15 years. We need to assess whether there has, what is the pubertal status of the boy and the girl, as well as the ovarian reserve in the female. Whereas the extrinsic factors which can influence is the risk of predicted treatment, whether it has high, medium, low, or uncertain risk to fertility, the time available with us before the treatment is initiated, as well as the expertise and the technical options which are available to us. So coming to the various techniques, in the female, in the pubertal, we could go in for oocyte cryopreservation, ovarian tissue cryopreservation, gonadal shielding, oophoropexy or ovarian transposition, as well as ovarian suppression with GnRH agonist. Whereas in the pre-pubertal, what the method we have is the ovarian tissue cryopreservation. We could also, to some extent, these patients would be helped by gonadal shielding, and ovary cryopreservation is still an experimental procedure. Whereas in the males, in the pubertal, we really do not have much problem because we can preserve the semen, and at times there are only few case series which have been reported wherein gonadal shielding could be useful. But in the pre-pubertal, again, we can see that for gonadal shielding, we have only a few cases, especially when they're subjected to radiotherapy. And moving testes out of the radiation field, there's only case series and still experimental. And we also know that testicular tissue cryopreservation has not yet been tested in the humans and is still experimental. And I will discuss in detail about it later. Coming to the adolescent female, we know that oocyte as well as ovarian tissue cryopreservation can be done. And pregnancy rates have been reported using cryopreserved oocytes, and the pregnancy rate is about 50%. After autotransplantation of ovarian tissue after OTC, it has definitely restored endocrine function in all. And live birth rate is also seen with a success rate of almost about 45%. And more than 14 live births have been reported after OTC has been done in adolescent population. One concern is contamination with malignant cells, which is seen in cryopreserved ovarian tissue. And this is basically, this has a higher incidence in those patients who have had leukemia. It has also been observed that there is no increase in the chromosomal abnormalities, birth defects, or developmental deficits that have been noted in children born after cryopreserved oocytes or after OTC as compared with other standard ART procedures and also with natural conception. The different sources of oocyte for fertility preservation basically are ovarian biopsy or oophorectomy specimen, wherein we do an ex vivo in vitro maturation. Basically, if she is pubertal, we can do ovarian stimulation with N2 oocyte cryopreservation. And we could also do in this group of patients in vivo IVM. And we can either, and this is followed basically by oocyte cryopreservation and whenever required fertilization and then embryo replacement either in the self or surrogate. And in vitro development of oocytes is still an experimental procedure. And if you look at the oocyte competence in the adolescent females, we can see that more mature oocytes are basically obtained in the postmenarchal girls. Whereas if you look at the IBM rate, it is again more in the postmenarchal girls as compared to the premenarchal girls. Coming to ovarian tissue cryopreservation, we know that it is the only method in prepubertal girls, and this is basically that it is and it has been helpful in those patients wherein they've had breast development, and the ovarian tissue transplant can result in puberty. And 2 live births have been reported after OTC, which is done in prepubertal girls, though there are more than 140 live births which have been reported after ovarian tissue cryopreservation and transplantation in the adolescent and the adult population. And here you can see that there is a definite restoration of the ovarian endocrine function, and you can see that the FSH levels come back to normal after about 4 to 5 months of ovarian transplantation. It has also led to induction of puberty, and here are 2 examples. And this was a girl who was a 10-year-old girl who had sickle cell disease, and transplantation was done at 13 years, and after 2 years she had her puberty. Whereas this was another girl who was a 9-year-old girl with Ewing sarcoma, and after transplantation at 13.6 years, after a period of about 19 months, she achieved menarche. And these are several papers which have shown restoration of ovarian activity and pregnancy after transplantation. And like, as I already said, that it has also been reported in prepubertal and postpubertal adolescent girls. But one must remember that the initial follicular density is of great importance to the longevity of the graft after ovarian tissue transplant. And though loss of ovarian follicles during the whole OTC and transplantation have been reported, there are several strategies that have been explored to preserve the follicles upon autografting, such as delivering angiogenic and anti-apoptotic factors and giving antioxidants and adipose-derived stem cells to increase the vascularization as well as decrease the ischemia after tissue grafting. We also need to look at those tissues which could have a risk of ovarian contamination, but we still don't have a strategy that has been developed. And basically, they are looking at IVG, wherein we do the in vitro growth, but it has a very low efficiency rate and abnormal morphology and mature oocytes have been formed. Or one could have an artificial ovary, and this has been tried in the mouse model, but there's no data in humans. The other strategies include gonadal shielding and oophoropexy, and oophoropexy has been effective in preserving the endocrine function of the ovary in 60% of the cases and in about approximately 15% of the patients who became pregnant. It has been shown that there were 42 live births which have been reported after oophoropexy before radiotherapy exposure. And the existing guidelines support that oophoropexy does not increase the risk of congenital abnormalities among offsprings. GnRH analogs are effective in restoring regular menstrual cycle for 1 to 17 years after the end of the treatment and are usually used as an adjuvant to other procedures for fertility preservation. No late complications from hormonal suppression were noted in most of these patients who were given the GnRH analogs. Following cranial irradiation, ovarian function can be supported at the time of family planning by use of gonadotropin therapy, especially in those patients who develop hypogonadism. Gestational surrogacy is an option in those who have undergone pelvic irradiation with scarring or other post-radiation effects to the uterus and vagina that preclude conception or the ability to maintain a pregnancy. And today, we also know that several cases have been successful after uterine transplant. We could also go for conservative surgery in girls, wherein we can preserve the ovarian function, especially in those patients who have had reproductive tract malignancy, and conservative surgery is possible in certain early stage tumors and choosing chemotherapeutic agents that have less gonadal toxicity. We could also generate oocytes and there could be regeneration of dysfunctional endometrium from stem cells. And it has been successful in mice wherein they have created oocytes from pluripotent stem cells. These oocytes could be fertilized, and one study resulted in healthy pups. Advances in the development of human germ cell line in vitro is being investigated and will be one of the fertility preservation techniques probably in future. Stem cells may be able to regenerate the dysfunctional uteri and to promote the vaginal reconstruction as well as regeneration. And as I said, uterine transplant is another jack on the block. And if you look at the evidence, we know that counseling is essential for all patients, both post-pubertal and pre-pubertal, who are receiving high dose or low dose alkylating agents or who are undergoing surgery, and probably also in those who are not at risk for infertility, but we could do fertility preservation if it is requested. Oocyte cryopreservation is done with high dose alkylating agents only if there is the cancer prognosis is good, and probably there's no delay in the treatment protocols. When we're using low dose alkylating, it is done only for those patients who are at high risk of cancer recurrence. And in patients wherein you are doing a unilateral oophorectomy, probably we have to do it in those patients who are at a higher risk of cancer recurrence, whereas for other treatments who are not at risk, only if the patient desires. Ovarian tissue cryopreservation is required in all those who are subjected to high dose alkylating agents, whereas those who are undergoing unilateral oophorectomy or other treatments, or who are taking drugs which do not have a risk of risk to fertility, they are not recommended. Oophoropexy again is recommended before radiotherapy to ovaries, and hormone suppression is not recommended and can be formulated. And basically, there are no recommendations that are formulated, but probably depends upon your experience and for what type, and depending upon the type of cancer she has. Coming to fertility preservation in adolescent boys, we know that sperm cryopreservation after masturbation is the most established and effective method of fertility preservation in male adolescent. And sperms are found in about 50% of the boys by the age of 14 years, and when the testicular volume is between 8 and 15 ml, and is considered when testicular volume is, and should be considered when the testicular volume is about 10 to 12 ml. Sperm cryopreservation after testicular aspiration or extraction, mass aspiration or MESA, electroejaculation or retrieve from the post-masturbation urine sample is also possible. And the sperms should be preferably collected before initiation of the cancer therapy, and the pregnancy rate and live birth rate range from 20 to 72%. Pregnancies were reported even with sperms that were stored for up to 28 years. Sperm collection after rectal electroejaculation under anesthesia and the testicular sperm extraction have also been successful, though they have been only case report or small case series. 3 live births were reported after ICSI with testicular sperm extraction in adolescent boys. Mature sperms, spermatogonia, and spermatogonal germ cells were observed after dissection of the testicular tissue, and these could be cryopreserved. There's no significant effect of hormonal gonadal protection noted during chemotherapy in reducing the risk of infertility. And here you can clearly see that boys between the age of 14 and 18 years have a similar sperm quality as compared to the adults. And if you look at the pre and post treatment azoospermia and the testicular sperm extraction, you can see that basically there has been almost of 50% success rate in sperm retrieval, and about 42% live birth rates have been reported. Coming to prepubertal boys, we know that sperm cryopreservation is not possible, and testicular tissue cryopreservation is the only option, and the approach to restore subsequent fertility is dependent on the preservation of the germ cells with the stem cells function within the cryopreserved tissue. And this testicular tissue, after cryopreservation, either we can do an autotransplantation or a xenotransplantation. We could also go in for in vitro maturation of the testicular tissue or stem cells, and we can do a germ cell transplant. Looking at the evidence for testicular tissue, animal studies suggest that immature testicular tissue cryopreservation with autotransplantation, xenotransplantation, and in vitro maturation resulted in long-term survival of the transplants and complete differentiation of immature germ cells into spermatozoa. Tissue collection must be well timed in order to minimize the impact of the disease or the treatment on the spermatogonial population. Human testicular tissue cryopreservation has been reported all over the world, and ongoing clinical trials are being conducted to address the issue of fertility preservation in prepubertal boys. This was a paper which was published in 2019, wherein they have had success with autologous grafting of cryopreserved prepubertal rhesus testes, and it produced sperms as well as offsprings. And if you look at the technique to restore fertility preservation after testicular biopsy in those testes which have been contaminated, you have option of in vitro sperm generation, but there's a lot of lack of markers to isolate the pure spermatogonal stem cells, and also poor survival and differentiation of these cells has been observed. You can do an explant testicular tissue culture, and the newer thing which has come is the use of organoids, but it has resulted in incomplete spermatogenesis in rats, and there has been no data for humans, though several experiments are going on. So when we talk about in vitro culture, it has resulted in full mammalian spermatogenesis in the mice, and in the humans, basically, they have tried wherein they have cultured these tissues for about 10 days, and they have seen formation of few sperms, and this then has been cryopreserved. And it has been shown that if you add anti-apoptotic components to the cryopreservation media, it enhances the spermatogonal survival. Coming to testicular organoids, it has been seen that 3D support given by the cellular aggregates was observed when newborn and juvenile rat testicular cells were cultured in rotation and allowed to form seminiferous tubule-like structures. Formation of organotypic testicular organoids in the microwell culture with a consistent testis-specific architecture was also seen in pig, mouse, and primate cells, which support cell type specific functions. In humans, first trimester human gonadal tissue fragment cells were cultured in vitro, having functional capability of producing hormones, which are known to play a major role in normal gonadal development. And when this media from the male gonad culture, it was examined, it showed strong positive correlation between AIIMS and NABNB levels, which are statistically significant, as well as the testosterone, AIIMS, and NABNB. And this also was statistically significant. There was another paper in 2017 which looked at preserved seminiferous tubule integrity with spermatogonal survival and induction of Sertoli and lytic cell maturation after a long time organoid culture of prepubertal human testicular tissue, and this tissue showed preservation of the spermatogonal seminiferous tubule integrity, showing paracrine interaction, intratubular proliferation, and survival of the spermatogonial cells for up to 139 days of culture, with progression to spermatogonal stem cells as well as Leydig cells and Sertoli cells to a mature stage. But this is still experimental, and we need to have further evidence for using these techniques. There was another paper in 2018 which looked at the haploid germ cell generation in organoid culture of testicular tissue from prepubertal boys. And it concluded that this represents a relevant milestone in the field of fertility preservation for prepubertal boys, and the differentiation of the germ cells up to a post-meiotic stage was noted when slow frozen thawed prepubertal testicular tissue from patients of different ages were cultured. The spermatogonia were maintained over the whole culture period. AIIMS secretion in the supernatant showed a significant progressive decrease during the culture period, and this was statistically significant. There was no variation in the androgen receptors seen per seminiferous tubules, and there was also no statistically significant variation in the number of SOX9 positive cells per Sertoli cells. On a histological assessment, differentiating germ cells corresponding to the spermatocyte and spermatids were also seen. There was another paper in 2017 which looked at three-dimensional testicular organoid in human spermatogenesis, and it showed that it mimics in vivo spermatogenesis by supporting the differentiation of the spermatogonal stem cells to the post-meiotic germ cells. This was another paper in 2017 in the stem cell reports, which looked at the primary human testicular cell self-organized into organoid and testicular tissue. And what they concluded was that primary human testicular cells are able to self-organize into human testicular organoids, which harbor spermatogonia and their important niche cells, which retain specific functionalities during long-term culture. There was another paper which was published in 2009, which looked at spermatogonal stem cell transplantation in vitro propagation in prepubertal boys who had prostatic cancer, wherein they had done a subculture of the germline stem cell clusters. But the risk of the spermatogonal stem cell propagation is tumor cell remaining in the testicular biopsy, spontaneous formation of ES-like colonies, and also epigenetic alterations in the spermatogonal stem cells with genetic mutation, histone cell modification, and DNA methylation changes. But probably there is some future for the spermatogonal stem cell propagation, and we could develop sperms and perform an ART which can result in a healthy offspring. There are a lot of ethical questions which are raised on non-spermatogonial stem cell-based fertility preservation in boys, wherein skin biopsies are used with the production of a healthy offspring. But again, we have a long way to go to use this technique. And if you look at the evidence for fertility preservation in prepubertal and pubertal adolescent, counseling is essential in all patients subjected to chemotherapy, cranial radiotherapy, and other treatment groups. Sperm cryopreservation is possible in pubertal and post-pubertal, both with high and low risk population, as well as those given cranial radiotherapy, but is not possible in prepubertal boys. Sperm cryopreservation using electroejaculation and TSA again is possible in all the groups, and testicular cryopreservation can be done in both prepubertal as well as postpubertal, those having a high risk of fertility after chemotherapy, but is not recommended in those who are subjected to low risk chemotherapeutic agents with cranial radiotherapy and other treatment groups, whereas hormonal suppression is not at all recommended in this group of patients. So I would like to end by saying that we should have an established and streamlined referral pathway with cancer diagnosis, wherein the oncology consultant has a treatment plan in place. And if there is risk of infertility, refers the patient to the for fertility preservation. And after seeing the fertility preservation consultant, we could either go ahead with the fertility preservation procedure and then start cancer therapy, or we could probably just go in for an expected management if the risk is low and start cancer treatment. And proper ideal referral form should be used when we do. Counseling and information are important to increase the knowledge, the satisfaction, as well as helpful in decision making, and also help in decreasing the decisional conflict as well as the regret if fertility preservation is not done in this group of patients. So I would like to conclude by saying that pubertal boys have an option of sperm cryopreservation and pubertal girls have an option of oocyte as well as ovarian tissue cryopreservation. In prepubertal girls and boys, cryopreservation of the ovarian and testicular tissue is the only available option to preserve fertility, as they do not produce mature gametes. Cryopreservation of ovarian tissue has proven clinically valid in terms of fertility restoration, whereas that of testicular tissue has not yet reached the stage of clinical applications, and human testicular xenografting can also be an option. But in vitro spermatogenesis and production of hormones has been achieved in humans, and in vitro re-engineering of the human testicular microenvironment from primary cells during 3D cell cultures has shown to achieve spermatogenesis in vitro. The potential benefit of oophoropexy before radiotherapy probably outweighs the potential harms in preventing premature ovarian insufficiency. Hormone suppression with the use of GnRH analog for fertility preservation requires a few resources and is feasible to implement to prevent loss of ovarian function. Fertility preservation in children and adolescent malignancies is complex but is essential, and the shift in treatment focus from childhood cancer patients from potential survival alone to the inclusion of fertility preservation is a reflection of advances in medical therapy. Research protocols are in place for developing methods for fertility preservation, especially for the pediatric population. The fertility preservation techniques continue to advance the opportunities for children and adolescents to have a reproductive potential for the future. And I thank you all for a patient hearing.
Just take it.
Mother, just to say hi.
No, he's going.
Thank you, Dr. Madhuri, for that very, very lucid presentation on what we can do actually for fertility preservation in adolescent and childhood cancers patients. And you have very, very beautifully shown us the whole journey from where we started and where we are now. And we are looking forwards that there would be a day when we will be able to realize the dream of many adolescent cancer patients by doing a successful ovarian tissue cryopreservation and testicular tissue cryopreservation and regrafting. And it has not only given a new dream to a lot of youngsters in the hall, and many who have joined on the hybrid mode, that we have to go miles before we sleep. A lot more work needs to be done.
Thank you, ma'am. Thank you, Dr. Anita, for giving me the opportunity to be chairperson. Dr. Madhuri ma'am, I know her quite few years. She's been doing a lot of work, and she was in JIPMAR in 2017 to sensitize regarding fertility preservation. We had a nice CME, but what was lacking is the support, which you had such a beautiful inauguration session where your director and the chief guest has supported you so much. And I'm sure that you will take forward to establish these fertility preservation facilities, especially and a public-private partnership, where even if your ovarian tissue is done in a private setup, because it needs long-term storage, institutes like AIIMS, JIPMA, and Chandigarh should offer a free storage. And as Dr. Pai said, we should form a consortium, fertility preservation consortium. I tried forming fertility preservation board in JIPMAR after the CME, which Dr. Madhuri Patel came and did. But what was lacking is the cooperation of the other departments like pediatrics and oncology, especially medical oncology, because most of these pediatric adolescents are in taken care by medical oncology department. We don't have a separate pediatric medical oncologists. We did a study on awareness 2019 and 20. 90% of these adolescents and young adults are aware of the cancer, aware of the survival, but they were not aware. Only 20% are aware of that fertility can be preserved after treatment, after survival, and they get the news, some of the educated, from the media. So we should take the help of the media also in taking forward this noble work. Thank you a lot. Thanks a lot.
Thank you, esteemed speaker and chairpersons, for the great session. We move on to the next session, which is the pre-lunch session. And for this, I invite a respected panel of chairpersons. Dr. Nalini Mahajan ma'am. Ma'am is Clinical Director, Maternal and Child Health Hospital, Delhi, and Founder President of Fertility Preservation Society of India. Dr. Sadhna Patwardhan. Ma'am is a Director, Nagpur Test Tube Baby Center and Dr. Ketkar Hospital, Nagpur. Ma'am, Dr. Tanya Bakshi. She is an internationally trained consultant and has helped set up the Oncofertility program for cancer survivors at the Max Hospital, India. Professor Anju Agarwal, ma'am is Professor, King George Medical University, Lucknow. I request Dr. Tanya Bakshi, ma'am, to introduce the speaker.
A very good afternoon to all. I would like to first start by thanking Professor Anita ma'am for this wonderful session and gathering such an incredible amount of students and variety of international speakers. So I shall move on, and we will start by yet another very exciting session by Professor Anderson. He's the Scientific Director of Laboratory of Reproductive Biology, University Hospital of Copenhagen, Denmark, Professor of Human Reproductive Physiology within the Faculty of Health and Medical Sciences at the University of Copenhagen. He was a member of the team that introduced IVF to Denmark in the mid-1980s. He is a senior accredited X-ray embryologist and has worked as a consultant with more than 10 fertility clinics nationally and internationally. Over the last 15 years, he has headed a national program of cryopreservation of human ovarian and testicular tissue, which is approved by the Danish authorities. He's considered one of the pioneers in this field and continues to expand the indications for the use of ovarian tissue cryopreservation in different clinical settings. His major research contributions has been in ovarian endocrinology, oocyte maturation, cryopreservation of gonadal tissue, human embryonic stem cells, and the development of new principles for ovarian stimulation, including the introduction of the agonist trigger and novel approaches to luteal phase support. We will now hear him talk about gamete collection in prepubertal children and adolescents, bench to bedside, oocyte and ovarian cryopreservation. Professor Anderson, such a pleasure to have you here.
Please unmute.
Kindly unmute, sir.
So, yes, hello. I need you to allow me to share my screen. I'm unable to share my screen.
You can do
please.
that, sir.
No, I cannot.
Just a moment. Could you try again, Prof?
Yes, now it may be better. Let me just see here.
Yes, sir. Yes, sir. You
yes.
just select, sir, PPT file.
I just need.
You just select your PPT file in below, sir.
Yes. Yeah.
Sir, if you could just select the PPT file, which is at the bottom of the screen.
It's do not, I don't see that. Let me.
Just at the bottom.
At the bottom, I do.
Yes, sir. Yes.
So.
Yes. Prof,
Do you see it now?
Yes.
You just make it full screen, sir. You just make it.
Is that all right?
That's perfect. Thank you.
That's perfect. Okay, thank you very much. Thank you for this invitation to talk to you about the special thing on fertility preservation in children. I'm going to talk to you about how oocyte and ovarian tissue cryopreservation can be performed in children. This is a very special case because children's ovaries are very different from adult ovaries. And I would like to point out to you what you need to take into consideration when you're doing this. What you see here on my first slide is actually an ovary from a 4-year-old girl. And you can see that this is now a millimeter paper below. So the ovary is actually very little. On the other hand, it's stuffed with follicles and you need to take this into consideration. So what I want to do today is to talk to you about the technical aspects of what we are doing when we freeze, especially ovarian tissue from children, because this is indeed different than we do when we are looking at adult women. So you need to take into consideration that this is now very small ovaries and they are the constitution of follicles inside the ovary is different. Then we have done quite a lot of children in Denmark. I would like to discuss the cohort of children that we are having in Denmark. And then the interesting thing, of course, is what happens if you transplant back an ovarian tissue which were not active, which hasn't matured sufficiently in the girl or woman to be active when you retrieve it. Does it work when you put it back? And often these young girls that we do it with, they may have a cancer, but they may also have rare genetic diseases where the issue is not alone that they have fewer follicles, but they also have a disease. I want to touch upon that as well. So, of course, it is a delicate matter to take prepubertal girls' ovaries because there is a risk that she will lose her fertility due to the disease or the genetic conditions that she has. On the other hand, and we have to balance this against that we are having an invasive procedure where we are taking out an ovary. And in many instances, we actually don't know whether the tissue is able to provide fertility when the girl grows up and have a desire to have children, especially in some of these rare genetic diseases. And this is the dilemma I think we have, and I think we need to balance out the different issues at stake here. And this is what I would like to touch upon today. So what other options do we have available? In adult women, we may want to use a GnRH agonist to downregulate the pituitary, so we have no FSH, no follicular recruitment. We cannot do that in prepubertal girls because the recruitment of follicles is not that high. Orthopreg-C, we can do that, but it's not always coming out the way we want. Cryopreservation of oocytes and cryopreservation of embryos. I'm actually, although my title indicates that I should talk about that, I'm not going to talk much about that because all the information we have available is that there is very few oocytes and they are very less likely to reach metaphase 2 once we have done IVM to them, as long as they are coming from young children. So this is really not a clinical option. It's not that you are unable to get any metaphase 2 oocytes. It just doesn't happen very often. And often, if you try to do it, it turns out that you're ending up with 1 or 2 metaphase 2 oocytes. And is this really now something that this girl is going to hope for in the future? I don't really think so. But freezing ovarian tissue we can do, especially because the ovarian tissue contains a lot of follicles. Let's just have a look at the activity that we are doing in Denmark. You can see here that this is now all our patient cohort divided into age. And the first group is from 0 to 5 years, and then all the way up to 35 and 40 years. You can actually see that we have quite a lot of girls who are less than 5 years old. The youngest one we have done is 3 months old. And if you take the young girls and adolescent girls up to the age of 15, you can see at the bottom that they make up 194 cases. So this is 14% of our entire cohort. So basically 1 in 7 of the patients treated in Denmark is a very young girl. So it is indeed a very significant group, and this is a group where this is the only option they have available in practical terms is freezing of ovarian tissue, at least in my opinion. And here you can see the age distribution from 0 to 3, 3 to 6. So certainly it is especially patients with who are in the higher group, which are now having these options offered. And I think it's also interesting just to have a look at the different diagnoses in these young girls. And as you see, then in the early years, leukemia, sarcoma, and genetic diseases are prevalent diagnoses, whereas when they grow a little older, the sarcoma and genetic diseases and leukemia for that matter also contribute to the diagnoses. But I guess that if we look at the different diagnoses that we use for freezing of the children, they quite closely reflect these distributions. So it is this, of course, reflects that the treatment they're receiving are highly gonadotoxic. I think that we get an idea of what we're talking about when we're looking at histological sections. This is a histological section of a human ovary just 3 months old. If you can follow my arrow on the screen, you can see that here we have an enormous amount of small primordial follicles, all resting follicles. So the ovary small in size, but stuffed with follicles. This is even more pronounced in this picture here, which is a histological section from a 2-year-old ovary. You can see that all the way out to the cortex and all the way in through the medulla, you have tightly packed follicles. So this is, of course, something we have to take into consideration when we are preparing the tissue, because in these very young girls, there's hardly any medulla, and we do not need to take out, we should not take out any tissue from this ovary. So what we normally do is that we would cut it into a sausage-like slice so that we get very thin slice of 1 millimeter, and then take the whole ovary and freeze. This is a picture of a 7-year-old girl's ovary which has been stained with GDF9 antibodies, and all the brown dots here represents primordial follicles. And here you can see in this particular case that there is not 1 millimeter outer surface where the follicles are located, but there is a medulla. So depending on the age, depending on the form of the ovary, we would need to decide how exactly we are preparing it. And if we look at the density of follicles, you can see here, this is a log scale. So the younger the ovaries are, the more follicles they contain, and they are basically stuffed with follicles in the young years. This is not surprising, but it do have an impact on how we prepare the tissue. This is a study at John Kelsey they have done in Edinburgh, where we have the ovarian volume here and the age here, and this is our cohort. So there's a lot more in Tom's cohort, but you can see that the ovaries in the young years are very small, 1 milliliter, 2 milliliters. They're not very big. And then they peak in maybe at 19 or 20 years of age. So this, of course, has an impact on how we should do it. I think that if you look at this, you can see that the ovarian volume is very different in relation to years. I'm sorry. Is there somebody who could please mute?
I'm speaking now. Shit.
You can see here the small ovary. This is hardly more than 1 centimeter long, and then they grow over the years and become almost a normal size in 10 years in this particular examples. And of course, in ovary like this, we wouldn't take out any medullary tissue. Here, we probably don't need to take out a lot of medullary tissue, but here in the older ones, we may. This is just to let you know how different in size of the same age that ovaries may be. So these are between 6 and 7 years old, and you see that they are very different in size. And we wouldn't prepare this ovarian tissue in a similar way, depending on which one it is. This one, we would probably freeze all the tissue, whereas this one is likely to have some medullary tissue. We would have a look at this when we cut the ovary into half and decide how we would like to prepare it. So this is how we do it normally in the adult tissue. We have an adult ovary where we preserve we isolate the cortex, small pieces, freeze them, and then we can transplant them one by one. This is a video of how we prepare a 3-year-old ovary. Now let's hope that this will work. It does, beautiful, that's very nice. You can see that we have now free hands in the flow bench. So we are actually 3 of us helping, 2 of us helping one another to prepare the ovary. So we're now slowly just cutting this ovary into half. This is just a very small ovary. This is only 1.5 milliliter in size. And then we would just very briefly remove some medullary tissue here. You can see that this is how it looks when we have prepared it. Hardly any medullary tissue is taken out. They are thicker, but these are thin enough to be cryopreserved individually. And then we would just cut them into pieces. When we have children's ovaries, we normally make the pieces smaller because the follicular content is so much higher that we would still have a lot of follicles in the ovary when we replace them. So this is just the rest of the procedure. We don't need to have a look at that. So we have now actually for the first time started to have some experience in how to transplant this tissue. So this is a paper which came out in the Journal of Assisted Reproduction and Genetics just last year, where we are describing our experience with transplanting ovarian tissue from girls who were very young at the time of freezing, and then what happened when we transplanted this tissue. Does it actually work, and how does it work? And here you can see that we have now in our cohort 6 young girls. The third one is maybe just about the age, but here's 9 years, 9.3, 0.5, 12, and 9. So these are young girls, and certainly, except for her, they were all pre-pubertal. And you can see the ovarian volume. This is what it is, age when they returned for transplantation, and the period that the tissue have been stored, and the different diagnoses, the amount of tissue that we transplanted. And so you can see that the first one we did was this one, just 20%, and here we actually transplanted 67%. So we are now putting more tissue back. And the interesting part, of course, is how does this tissue respond once it's transplanted to these adult women? They have never seen circulating levels of FSH. So the interesting part, of course, was to see how does this prepubertal tissue now behave when you transplant it back to the adult woman. And actually, you can see that FSH and LH, they come back. There's a small bump here and there, but overall, after 20-25 weeks, the tissue becomes active also when the tissue was prepubertal when it was transplanted. So this is really good news and tells us that this tissue will respond to the endogenous levels of FSH and LH, and that shows that it do work. Actually, this is the right-hand panel here. At the bottom is AMH. We didn't have that on all of them because some are so early we didn't measure AMH, but you can see that it corresponds to the fact that after 10, 15 weeks, the ovary becomes active and the follicles reach the size where they start to secrete AMH. So this actually fits quite nicely what we want. The difference in estradiol here over weeks is a little pronounced. So this is those which were adult when they were cryopreserved, so they take up estradiol faster. And this is probably just reflecting that these follicles take a little more time to come up. They are coming up here. So these are probably just having a little extra time to really produce estradiol in preovulatory levels. So we have had one successful woman who have had tissue transplanted when it was frozen when she was young, 9 years old. And this is a picture, this is a case we actually did publish some years ago, and she had thalassemia, so a genetic disease. And I just want to point out that you probably in India are having a lot of these patients who may benefit from having their tissue cryopreserved, provided that they are going to have a bone marrow transplantation in connection with treatment of their beta thalassemia. So this particular woman was from the United Arab Emirates. She suffered from thalassemia. She went to Leeds in the UK with Roger Gost and had her tissue frozen in 2001 when she was 9. She came to Denmark in 2015 to have her tissue. This was brought here. She had her tissue transplanted, and after that she returned to UK and had IVF treatment and gave birth to a child. The new and interesting thing is that this particular woman, based on what she had transplanted originally, now not more than a year ago, had her second baby from the same transplant. So although this was transplanted in 2015, it is still working and still have provided her with an additional baby. So this is really good news. This is just to let you know how it looked. FSH yellow, LH pink, and AMH red. And you can see that she had high levels here, no AMH. We transplant the tissue here, and then it do come up. And we have AMH coming up. We have a little fluctuation of FSH. This is normally what we see when we transplant the tissue. So these 5 pieces of tissue were transplanted here, and this still works. So this is absolutely nice. So if we are having a look at the follicular density in women, in girls with thalassemia compared to age, you can see here we have actually now collected 2 types of diagnoses, thalassemia and sickle cell anemia, which are related. You can actually see that the gray ones are normal girls who don't have a genetic disease. They may have a cancer, but the 95% confidence interval is pretty huge. But most of these actually fall within. So there's a very good reason to take and freeze these girls' ovaries before they receive bone marrow transplantation, if this is what they need. This is just to show you a picture from a girl who have thalassemia. The follicles look exactly as we would like them. Their morphology is very good. So, and this is now just confirming what we have seen. So the initial study we did in 2012, this is now indeed published a long time ago, but this was used to induce puberty in this particular girl who had her tissue frozen when she was 9, and she had it transplanted when she was 13. And you can see that FSH came down, came up here, actually came down later on, and she had her puberty. So this was just used to induce puberty, and this is also what you may use the tissue for if this is very young girls. The argument, of course, is that if you use 2 pieces of tissue, if you have 10 pieces frozen, she will still have 80% left, 80% of her one ovary. The number of follicles this corresponds to is far more than we freeze from women who are 25 years of age or older. So they still have a huge amount of follicles to help them. This is a study from Catherine Parot in France, who also transplanted a young girl to induce puberty, and indeed saw that FSH fell and estradiol also increased. So she was also able to help this girl. So this is an indication which may be considered if you have sufficient tissue. So often these girls would be girls with leukemia, so they would often end up having had treatment before they actually have the tissue cryopreserved. So we did a study in 2016 where we looked at those at the follicular density. So how many follicles did these patients lose due to the initial treatment before chemotherapy? So as you can see here, that the majority of those who had chemotherapy before we froze their ovary had leukemia. There's other ones with Ewing sarcoma, Hodgkin, and other cancers. But indeed, this is majority of patients, and as compared to what happens in this group where they did not have treatment. So if we look at their follicular density, so now this is follicles per cubic millimeter of ovarian cortex. You can see that the ones with treatment before ovarian tissue freezing and those who did not are absolutely similar. So we are unable to see. So the induction cure that these leukemic girls have in order to make them conditioned so that they don't have malignant cells circulating are not severely gonadotoxic. What we also had a look at was that we looked at the ovarian volume. And here you can see that those who did not have chemo before tissue freezing had a higher volume than those who have had it. And as we are isolating just the cortex, this actually means that there should be fewer follicles totally in those with smaller ovarian volume. So if you calculate that in relation to age, you can see that the estimated ovarian reserve after treatment, taking the volume into consideration, is 90% for 2 years, but it actually drops almost 30% in those which are most frequent, 10, 12, 14, 16, and 18 years of age. But I certainly do not think that the reduction in follicle numbers here do not justify that we offer them tissue freezing. There's still a lot of follicles sitting in there, and the 70% of follicles in one ovary from an 18-year-old corresponds nicely to what a 25, 28-year-old woman would have. It's interesting now that, and this is mainly girls, that if we start to look at what has happened with leukemia, obviously this is the most difficult diagnosis for us, and we have to be very cautious to see that we don't introduce a relapse to these women. I actually just want to show you that we have now 15 patients who have had ovarian tissue transplanted with a former leukemic diagnosis, and these are all the ones which has been published, as you can see them here, and a lot of them actually now have had children. Obviously, this is still a very delicate group to do it in and require a lot of preventive measures, but at least neither of these 15 women there has been any reports of relapse. I'm certainly aware of that this will be a biased information we will have. People may not want to tell us that they have reintroduced the leukemia, but up until now, there is a very cautious approach to this, and I think that this is interesting. I just want to finish off by showing you that we have now looked at Turner syndrome patients where we do know that the follicles may disappear very early on. And is this because there's a genetic mismatch with one X chromosome too little, or is there something inherent wrong with these follicles? Here you can see that we have now looked at Turner patient in the same manner as we did previously with thalassemia and sickle cell anemia. They actually also included here, but the blue ones are now Turner syndrome patients. And you can see that if we look at them, a lot of these Turner syndrome patients, sorry for that, actually have follicular densities which are in the normal range, especially if they're mosaic. Turner syndrome patients. I know that this is also a delicate matter to say they mosaic, because what are they in their ovaries? But it do turn out that some of them actually have sufficient number of follicles, which is a very good starting point. We have now looked at Turner syndrome follicles, their follicles, and stained for different important markers of follicular health, AMH, DDF9, BMP15, IGF, BP4, PAB, and staniocyansin 2. And actually, this is now the control, and here's 3 Turner syndrome patients. And basically, the follicles in many instances actually show a similar staining pattern. So it do turn out that, at least from the expression pattern of these markers, that the follicles often are okay. So I do think that there's an interest, and we are now actually putting up a larger project in Denmark looking at the Turner syndrome patients. Will they benefit once they have the tissue transplanted? This is, of course, the difficult part. But if we do not try it out, make informed consent from the patients, we will not have the experience. So I do think it's justified to go ahead. And if you finish off by an international consensus of, if you asking young Turner patients syndrome, they actually come out and say that they're very interested in this, and an expert panel is suggesting that this is now justified. Excuse me. So I think that this is something we'll hear a lot more about in the coming years. So finishing off with conclusions, I think it's feasible to freeze ovarian tissue from children. It is justified. We can do it technically, and we do have surviving follicles which will be working once we transplant the tissue to now the adult woman. So this is very nice. I think genetic diseases like thalassemia, sickle cell anemia certainly appear to benefit from freezing tissue if they're going through chemotherapy to prepare them. And I think that Turner syndrome patients, they would still await a proof of concept. We have to see that this actually benefits these patients when we transplant it. And I guess that this will not take long before we actually have the first experience. So I'll finish off with this, and thank you for your for listening to me.
Professor Claus, I think there is a standing ovation from all of us for this brilliant presentation. I want all my students to get up and give him this. It was a wonderful, wonderful presentation, and you have shown that we can do this. You have done it, and we will definitely look forward that we are able to preserve the fertility in these young cancer survivors and are able to give them the joy of parenthood later. Excellent talk.
Okay, thank you very much.
Can I ask a question?
Yes.
Nita, can I ask a question?
Yes, ma'am, you can.
Hi, Professor Claus. It was wonderful hearing you after such a long time again. And I just wanted to know, is there a concern, obstetric concern for these Turner syndrome patients? We are transplanting, but we also know that they have a very serious, they can have very serious issues, especially cardiac, if they become pregnant. So was that concern thought about when you were looking at freezing and then transplant?
Of course, you're right. We do know that Turner syndrome patients have difficulties having pregnancies. It's just difficult. That argument is difficult in Denmark. Here, they are actually allowed to have oocyte donation. And I guess that the pregnancy will be of similar complications if you have oocyte donation than if you use your own tissue. And therefore it's difficult to say, oh, but you cannot have your tissue frozen because you may have difficulties with your pregnancy. If they can go next door to the fertility clinic in a public healthcare sector here and say, could you please provide me with oocyte donation? And I think that this is the case in many European countries where we are saying, well, when let's try and see if this now will provide them with their own biological children.
Professor Claus, I may ask you a question that most of these women who went for allografting or xenografting, where did you grafted the ovary, the frozen ovarian pieces which you had shown, which you regrafted?
Yeah, no, that's also a very good question. I think that we often in these young, the very young girls, their ovary are very small. The remaining one which is sitting in there, which was experiencing chemotherapy when she was just a child. So often we would need to put this into peritoneal pockets because the remaining ovary is simply too small to harbor more than 1 or 2 pieces of tissue. We do, if it is possible, we often try to put them into the remaining ovary because this, I think that this will provide her with natural fertility and is the place where the tissue basically should be positioned. But this is not possible, so we put them into peritoneal pocket most of the time.
Would any of my co-chairs, Sadhna ma'am, Anju ma'am, would you like to ask any question?
Thank you so much, Professor Claus. It has been such a wonderful presentation and you have really clarified matters, and we really look forward to looking to your results in the Turner syndrome patients. It is a very exciting research and we have really enjoyed the presentation. Thank you so much.
Thank you very much. This is very good.
There's one question, Prof, from the chat box. Dr. Prasad, what is the risk of contamination with malignant cells when you're retransplanting? And I think what everyone wants to know, do you retest or do you do any testing on the tissue before you retransplant?
We don't do this when the diagnosis is breast cancer or Ewing sarcoma. We have morbus Hodgkin. We don't do it because we have now a great experience, and I have all the centers which are doing lots of transplantation do not see relapses from these diagnoses. The one where we are all very cautious, of course, is leukemia. And this is why I actually draw the results out for you so that you could see that now 15 patients have been transplanted. But here, whenever we are having a leukemic diagnosis, we indeed do have cases in Denmark where we have said we do not dare to transplant tissue to you. But if we are unable, if we transplant it to a nude mouse for 20 weeks and the mouse is healthy and we are unable to detect any genetic markers, I think you all should do, if you're freezing ovarian tissue from leukemic patients, make sure that you have a blood sample stored with the tissue, because it may be that you are unable to detect any marker from this particular woman where she has a genetic marker on her leukemia. But there's new markers coming up all the time. And when she returns and asks for transplantation, there may actually be a marker in the blood at the time when she had the tissue frozen, which you now know, and where you can look for this particular marker in the tissue. And if the marker is absent, you actually now, these genetic methods are very sensitive. And if you are unable to see it in the tissue, this is where most people now, these 15 women, if you're unable to see that marker, although this was leukemia, you would say that the load is now so low that the risk of transplanting the tissue is probably very, very small. So this is where it stands at the moment. I do think that leukemia and some other diagnoses, rare diagnoses, you really have to be careful. But a lot of the most common ones, breast cancer, morbus Hodgkin, Ewing sarcoma, we have not seen relapses due to the ovarian tissue.
Thank you. Just a last question, Prof. What was the longest time period? I mean, you showed that when you retransplanted in the lady where with thalassemia, it lasted quite a while, actually, the graft. What about the younger girls? You know, you've done it in even the 0 to 5 age group. You have a substantial number. What is the average that you're looking at that the graft usually survives?
We haven't transplanted any girls who had their tissue frozen between 0 and 5 years. This is simply because that we haven't done it for so long that those girls, they have not reached an age where they want to have children yet. So they're just stored in liquid nitrogen. So I do think that the youngest we have done is 9 years old. But I'm sure that they will be coming, because now time is running, and the tissue that we froze now 15 years ago, they are slowly getting to an age where they may want to use their ovarian tissue. So I'm unable to answer for the very young.
And as you showed for one of the girls where the induction of puberty actually did take place. So I think that's again an increasing indication that we'll see and probably get more data from these girls as well. Thank you very much.
Thank you. All right.
Thank you.
Thank you.
Thank you, esteemed
Have a nice
speaker,
conference.
and thank you, esteemed speaker and the chairpersons. It was a very, very informative session. Now, I cordially invite the dignitaries and the delegates for lunch. We will resume in 20 minutes. Thank you.
Thank you.
Lunch. Super
See
quick
you all
lunch.
back very soon.
So I welcome everyone after lunch. So without undue delay, let's move to the next session. And for the same, I would like to invite our esteemed chairpersons, Dr. Firoza Parekh. Sir is Director, Department of Assisted Reproduction and Genetics in Jaslok Hospital. Ma'am, sorry. Dr. Firoza Parekh, apologies. So ma'am is Director, Department of Assisted Reproduction and Genetics in Jaslok Hospital, responsible for Southeast Asia's first ICSI baby Love Singh in 1994, and Editor-in-Chief, Fertility and Sterility, Indian edition. Professor Sameer Bakshi, sir. Sir is Professor, Department of Medical Oncology, AIIMS, New Delhi, with special interest in pediatric oncology. And Professor Sanjeeva Reddy, who is Professor and HOD of Department of Reproductive Medicine and Surgery, Sri Ramchandra Medical College. So now may I request Professor Sameer Bakshi, sir, to invite the speaker for the next session. Over to you, sir.
Good afternoon, everybody. It's my pleasure to invite Dr. Mohammad Faisal Ahmed from Malaysia to speak on sperm retrieval and cryopreservation in prepubertal children. Dr. Mohammad Faisal bin Ahmed is a clinical specialist and lecturer of OBGYN in the Hospital Chancellor Tongku Mukrez University Hospital, and his special interest is reproductive endocrinology and oncofertility. Over to you, sir.
Thank you very much. Thank you very much for the introduction. So the topic that be given to me is this sperm retrieval and cryopreservation in prepubertal children, as compared to our previous lecture, which is the ovarian as well as oocyte cryopreservation in children is more established. But here in this topic, we will discuss more on the experience and experiments method that had been established and what we are going from now. So the male gonad contains spermatogonial stem cells that is a foundation of spermatogenesis that leads to matured and fertilization competent spermatozoa. Germ cell loss can be induced by cytotoxic treatment, as we know, but it's also linked to hereditary conditions such as Klinefelter syndrome and Fanconi syndrome. Thus, fertility preservation need to be advocated in this kind of cases. So as we know, the seminal parameter in health adolescent and young adult is more or less is the same. However, the numbers of the is lesser, as well as the sperm mortality is also lesser. But we need to know that this adolescents is a special population that need to be catered in this current situation of oncofertility in this special population. So as we know that the effect of chemotherapy and radiotherapy have a tremendous effect in the gonad, as well, especially at the seminiferous epithelium of the testes. As you know that if the higher doses, if used in radiotherapy or chemotherapy, they will actually lead to the gonadotoxicity and also Leydig cells toxicity, and lead to the arrested of the spermatogonia process and lead to infertility in future. So as we know that the stems, spermatogonia stem cell is the most immature stem cell, and the second one is differentiated spermatogonia. The differentiating spermatogonia is the one that been numerous in our special population in prepubertal, in which they have self-renewal about 27 days. And the differentiation is according to the schedule as well as the patient profile. However, this is very sad because this kind of cell is extremely sensitive to be killed by most anti-cancer agent, and it not been repaired in molecular level of the DNA should it be exposed to the chemotherapy or radiotherapy. So we need to prevent this from happen in order to improve and preserve the fertility in future, as compared to other stages of the spermatogenesis, which is the spermatid with testicular sperm, and so on as a matured sperm that is actually resistant to by many of anti-cancer, depending on the subtype as well as the modericity and the severity of the agent that used. So the impact of chemotherapy, radiation, and surgery on the prepubertal gonad is very well established. That radiation is depending on the dose and the fractionation schedule and the field of radiation. The prepubertal testes are more affected by the treatment than compared to the mature testes, and radio sensitivity is much lower in Leydig cell than in the spermatogenate cell. If the children have the cranial irradiation of the brain tumor, also it can actually help essentially lead to disturбance of the hepatomegaly pituitary gonadal axis and lead to endocrine failure. As I mentioned earlier about the chemotherapy, is depend on the agent administered and cumulative dose that they receive, as well as the surgery. Most of our patients receive the surgery in prepubertal in order to for testicular cancer. They lead to gonadotrophin deficiency that develop when hypothalamus and pituitary gland damaged by the surgery. The testicular cancer associated with impair in sperm parameter, and it been further propagated if the patient need to undergo orchidectomy. On top of the normal surgery, then we do a retroperitoneal procedure such as resection of retroperitoneal lymph node in the case of testicular cancer or sarcoma that can lead to infertility by damage nerve responsible and cause great indication in future when the patient is puberty. So in the prepubertal male patient, we already know that the sperm banking is play an important role in this fertility preservation, and it's important for us to initiate this prior to the chemotherapy. Even though the patient receive a small or low dose of gonadotoxic, but it can affect the quality of that. That's why we need to make it clear that we need to do a sperm freezing prior to the chemotherapy. In the case where the failure of the patient to produce sample by masturbation, we can assist it with the penile vitellovenous stimulation or electroejaculation under anesthesia as a second line option. However, our concern and our problem is more on prepubertal male, as the challenge for fertility preservation is they cannot produce a sperm, thus they cannot do a established method with sperm cryopreservation. The germ cell of prepubertal testes, including the spermatogonia stem cell, do not have any matured spermatogonia, thus we have some sort of like problem. So should we cryopreserve this testicular tissue, because we currently have no idea what we can offer to them in future. Although we know that fertility preservation in puberty is still in infancy, but we know that it's progressing in this field, and we need to balance the biologically, clinically, and technical knowledge in order to improve the outcome, as well as to cater the ethical and legal question to enhance the awareness among the parents and our colleagues oncologists. So what we have now for fertility preservation in boy, we have sperm prism, which is established if the patient can able to produce a sperm. We have spermatogonia stem cell with the SC transplantation, testicular tissue grafting, as well as in vitro spermatogenesis. So this is the cartoon that actually highlighted the option that we have for the fertility preservation in young boy with no sperm retrieval. We can do a testicular biopsy, and we can do the isolation of the single cell or spermatogonia stem cell propagation, and we can actually inject this into the Leydig cell and achieve the maturation later, or we can just do a grafting on which is the grafting onto the previous scrotum and actually achieve the spermatogenesis from there, or we can actually put it in the 2D or 3D culture to improve the in vitro spermatogenesis, then lead to a matured sperm and use it with ICSI and help the patient to get the baby. But which one is more superior, which one is available, then we can answer it along the way with this lecture. So the first one is spermatogonial stem cell propagation and autotransplant. This in vitro propagation of the SSC followed by autotransplant in the seminiferous tubule via rectal testis is considered the only method that available for restoration of fertility to aim for natural conception. In this method, what we do is we actually isolate the spermatogonia stem cell from the testicular tissue that we biopsy and propagate this stem cell to make it mature. When the stem cell already mature and good enough to be injected into the rectal testis of the patient, and once the patient has already completed the chemotherapy, and we can actually allow the patient to have their own baby via intercourse. So this is tremendously excellent theoretically, whereby it can actually help in sense of achieving pregnancy naturally. Some of the SCC can also be matured spermatogenesis via the in vitro spermatogenesis using 2D or 3D culture, as well as the organ culture model, and harvest the mature oocyte, and we proceed with ICSI and actually offer the patient the fertility treatment via ART. However, what is the main concern of this is we didn't know whether the residual or the malignant cell is actually present in the stem cell, does lead to the contamination of the gamete, as well as remission of the reoccurrence of the cancer in future. Therefore, one of the things that we also need to know is when the patient already receives some chemotherapy or they have some DNA problem, they can actually have this genetic mutation on top of this propagation and lead to the inherited of the disease in future. So some of the stem cell also fail to complete meiosis and arrest during the injection, as well as lead to the infertility. So we have one landmark study that actually helped to answer the question whether the spermatogonia stem cell is achievable or not for the pregnancy. So they have been established by Brian Herman in 2012, whereby they have a successful embryo that produced by the matured sperm following spermatogonial stem cell transplantation into the rectal testes of the rat. You can see here the testes and the rectal testes of the needle to the testis, and they actually do some sort of IHC and gene expression to see the maturation of the sperm, as well as they collected 85 of the oocyte and do an ICSI for them. 81 oocyte actually produce a good embryo ranging for 4 cell to blastocyst, and you can see here in my left right hand side there is a good embryo development up to blastocyst day 7 and hatching, but they didn't actually proceed to a pregnancy to see whether there is a production of any offspring. But what is the pitfall of this method? It's very complex. When you want to translate this technique into the human tissue, they need to sort out for a selected marker to determine the migration of the SSC niche into the seminiferous membrane after the human transplantation, and it's very complex to monitor whether the SSC have been matured or not. So there's multiple complex marker that been undergoing evaluation for now in order to improve this technique to be implemented in human. In terms of epigenetic aspect, they also concerned about the stability and the safety. When we do a propagate of SSC, noted there is some sort of contamination and also increased risk of malignant transformation following the animal model, and also the introduction of cancer cell, especially in non-solid tumors such as leukemia or blood metastasis tumor. So it's still being debated as well as being evaluated in order to translate into the human aspect to make it better for human study later in future. The second thing is testicular tissue autografting. The testicular tissue autografting is the transplantation of the fragment of testicular tissue, which provide alternative strategy to us to use rather to use the SSC suspension as before. So in this technique, they will maintain the SSC within the unexposed natural niche and preserve the interaction between the germ cell and the supporting somatic cell, so that there's no arrested or mitosis, and there will be a lot of improvement in terms of nutrition and support. However, we need to exclude malignancy by assessment of the minimal residual disease from whatever method such as flow cytometry or gene expression. And up to now, there's no established protocol of testicular tissue freezing, whether you want to use slow freezing, vitrification, and what type of media for cryoprotectant that you want to use is depending on your center and your center experience. So this is how they propose for the testicular tissue freezing, whereby they will do a direct testicular biopsy and cut into the pieces and put into cryoprotectant as preferred by the center, and do a method of cryopreservation depending on vitrification or slow freezing, because it's both are considered equivalent, and they will store the tissue later for future use. So the grafting of the tore tissue has been debated whether it's atopic or homotopic location. Initially, in animal model, they actually do a lot of different sites such as peritoneal space, ear, under the back of skin, and so forth and so on. But when we noted that from the beginning of the fundamental aspect of this grafting, they noted that higher temperature of the atopic site compared to the scrotum lead to the mitotic arrested and also altered the spermatogenesis. Therefore, therefore, they suggested that wherever we take out from the scrotum should go into the scrotum again. And they noted that there is a very good promotion of spermatogenesis when you put it in the scrotum due to the temperature. Then they subsequently they proposed that this is the best place for you to do the auto-transplantation of the grafting. So they have proven from the mice model that this testicular tissue cryopreservation have able to produce an offspring from the Japanese team Tetsuhiro Yukanishi in 2014. They have done this testicular tissue cryopreservation using both method, vitrification and also slow freezing, and they noted that the different kind of cryoprotectant affect the outcome of testicular tissue grafting survival rate as compared to the method of freezing, and they managed to actually produce and good evidence of offspring from the mice. Subsequently, the same country have proposed the testicular tissue to a non-human primate, which is a monkey, and using the similar method, which is cryopreservation of the testicular tissue, and grafting was done in the scrotum area, and they harvest back the sperm about 7 to 5 years later. And in 2017, the first graft-derived sperm was used, and following the ICSI, and they noted there is a formation, a good blastocyst, and implant into the surrogate monkey. And in 16 April 2018, Gardi, the monkey, is born to actually have this most landmark so-called image of the testicular tissue cryopreservation that can actually give us some idea that this technique can be used. So this is the so-called Bloom so-called a landmark study for us now to consider this testicular tissue freezing as one of the options. However, up to now, what is the progress in human? They already done in pig, cattle, goat, sheep, horse, cat, and also monkey, but there's none in adult human, because when you transplant the testicular tissue pre-pubertal to the xenografting, you can see that there's arrested of spermatogenesis. So we still in the puzzle of coming to produce a good media, good technique, what type of cryoprotectant and the percentage of each of the media in order to improve the spermatogenesis in human tissue. So last but not least, the in vitro differentiation of the male germ cell. This is the third technique that been postulated for our fertility preservation among boys, that in vitro generated sperm for fertility restoration have been shown good result in adult azoospermia patient. They took this adult stem cell and they proposed it in vitro maturation, and it differentiate into the primary spermatocyte to half blood cell, and it been observed at 48 hours, and this half blood cell have been reported become functional, and they result in birth with ICSI. So this is the group of Tesarik in 1999, more back then, more about 20 years ago. They already proposed that the restoration of the spermatogenesis can be achieved via in vitro maturation of the stem cell. So when they propose for a stem cell maturation of spermatogenesis in vitro, they come up with these 5 participants, and all these participants have good DNA content, and after a while of culture, they noted that there is a good sperm, that spermatid states that can be used for fertilization, and they inject into the metaphysic oocyte, 12 of this person and 6 for this person, and we can see the following. Then they can see the cleavage of good embryo at the 6, and 1 pregnancy was achieved with twin as outcome as in this study. So this actually gives us an idea that we can actually do this for our boys. However, in prepubertal field, the first testicular prepubertal rat was performed early in 1964, and they put this thin layer of argos as a promotion to stimulate the culture between medium and air, and they think that this method can actually improve the part-time spermatogenesis stage in the testicular tissue, and they noted that this new technique that they have proposed in that era can help in improvement of the spermatogenesis. However, up to now, they noted that the work have shown that this problem with this, they can actually achieve a good spermatocyte, but in the human tissue, they cannot actually produce a complete spermatogenesis. They might have some sort of like spermatid or some sort of like round sperm, but they cannot have a complete spermatogenesis from the human tissue. So this is one of the example of the higher achievement of this technique using the in vitro differentiation of the rat spermatogonia that been promoted to develop into a round spermatid in tissue culture. You can see that here they use prepubertal tissue. We have only round seminiferous tubule, and after the promotion of the in vitro maturation spermatogenesis, you can see from the round tissue, it can actually harvest in vitro the spermatocyte as well as the round sperm. So in conclusion from this Reda et al. In 2016, they said that there is a successful of in vitro differentiation in prepubertal tissue from undifferentiated into a complex and differentiated complete spermatogenesis being achieved, but they cannot actually prove to us that they have this complete spermatogenesis that can actually function. Therefore, they have no production of offspring yet up to now from this method. So then they conclude that they also try to escalate this into the human tissue, but this very much different in physiology, and they can still arrest the spermatogenesis at the earliest stage if they use the human tissue. So up to now, there's no conclusion whether we can use this or not. So the only thing that we can actually achieve now is based on the testicular tissue freezing. So how about our experience, or my experience with my team in Japan? Actually, when I been invited back to Japan to continue my fellowship on fertility, we already established the ovarian tissue in Asia under the Asian Society of Fertility Preservation, and in Japan it's like tremendously working well. So Professor Suzuki, which is my mentor in Saint Marina University of Medicine, Kanagawa, Tokyo, Japan, has initiated a testicular tissue cryopreservation. So we actually try to mimic the process of testicular tissue cryopreservation in order to ensure that the vitrification that we will use now as compared to slow freezing has a good promotion for a thawing later for spermatogenesis. So we use this 5 days post-pubertal mice. Then I harvest the testes, which is still at the area of the abdomen, and this is the adult mice that I do an orchidectomy. Then I implant the fresh tissue, frozen thaw tissue from slow freezing, as well as vitrification at the scrotum area, and the result is still ongoing. So we yet to harvest this result, and we escalate this into the cyclus monkey in Osaka, that whereby we take this prepubertal monkey, I think age about 8 years old, and still don't have any spermatogenesis. Very big testes, very big. So we need to cut it out, and we try to propose for our own formulated media using the same slow freezing, vitrification, and fresh technique. And we now in the process of still in process of frozen of the tissue, and we plan to transplant the tissue later, maybe in 1 year time. So it's still ongoing. So hopefully with this Japanese team can actually share some experience that we have in our own local data in how actually the fertility preservation in prepubertal is actually what is the outcome that we can actually achieve. So as a conclusion, we only have 3 techniques so far: the SSCT, testicular tissue cryopreservation, and in vitro spermatogenesis. So which one is the best now at this moment? I think the testicular tissue cryopreservation is still a good method that need to be developed in order to improve and implement in our prepubertal boys. So the current challenge in this field is we need to have standardization of protocol for the collection and cryopreservation of testicular tissue among prepubertal, and we as a team need to optimize the protocol for management and transportation of the tissue, as well as to develop the protocol for the quality reassurance before and after store, and to actually lead this to assessment of minimal residual disease to reduce the anxiety as well as our anxiety also when we transplant back, and follow up the patient thereafter. And as us want to emerge in this field of fertility preservation in prepubertal boy, we need to be a clinician scientist, in which we need to develop a lot of research to develop a good protocol for cell sorting in SCC, optimize the SCC protocol, obtain the proof of concept using human. Now we have all in mice and also primate, then we need to do in human. This is the time now because we already have all the proof of concept in murine model, and develop our own IVM for human SSC. We have IVM in oocyte, but we not yet have IVM in sperm, and we need to evaluate with geneticists regarding the genetic and epigenetic stability for us to move forward and assess the fertilization capacity of the sperm that we preserve from prepubertal. So as the conclusion, fertility preservation is increasing for the boys, and the technique is already been proof of concept in all the animal, but still in infancy at the human stage. Until the successful clinical trial demonstrated the safety and efficacy, the fertility preservation among boys still remain experimental, and we as a scientist clinician need to do more research to consolidate the evidence for us to share in future. With that, thank you very much for listening.
I'll request my co-chair, Dr. Feroza Patel, to open the discussion. Thank you, Dr. Mohammed, and Dr. Feroza will open the discussion, and then I'll join in later.
Dr. Ahmed, first of all, my hearty congratulations for all the fantastic work you are doing. I have two questions to ask you. For these young men or boys where we are considering fertility preservation, how will you select and tell the parents that, okay, these are the genetic markers that we will do for this boy, and if these genetic markers are normal, then we will go on to fertility preservation? How will you select these boys? Because we know that men with particularly testicular cancer and other forms of cancer can have diminishing fertility potential with their sperm. Thank you.
Thank you very much, Dr. Feroza. So basically, in our country, in my experience, we are at the infancy, I told you, we are at the stage of we will offer all the prepubertal boy for testicular tissue cryopreservation, regardless whether they have this kind of condition or not. Because at this moment, we are at the stage of developing the protocol to ensure that we can actually store the tissue accurately. After that, we already have some discussion with our geneticists to enhance the evaluation of the tissue later before we transplant. So that one, I for sure that we will do some work of protocol to enhance the assessment of genetic, whether they have some inherited genes or not, later in future before we transplant. So for now, not yet. I didn't do anything yet for now.
No, it's a very important marker because we give hope to these patients, to their parents. Yeah. But in the long run, and you're doing fantastic work, there is no doubt about it. In the long run, what will we tell these parents? What will we tell the boys? As a follow-up to this, my question to you is, I've never understood that why is it that young boys with testicular cancer particularly have very poor sperm parameters? Can you shed some light on this?
Okay. I receive now when I started my oncofertility services, I received more than 30 patients who actually prepubertal that have testicular cancer. 80% of them, as also reported in literature, have azoospermia because the pathology itself impair the maturation of the germ cell. Therefore, they affect the spermatogenesis in the other side, which is normal. although I try to do oncotese for the normal side, I cannot find any sperm. This is proven in literature. They already highlighted that the spermatogenesis is impaired genetically in the patient with testicular cancer. Therefore, before I start to offer oncotese for this kind of patient, I will tell the mom that I might need to have any sperm that retrieve from this procedure, because it's already known that the spermatogenesis is impaired due to the genetic itself. So it's maybe due to the genetic, or maybe due to the process of the disease that is accelerate and arrested all the mitosis process in spermatogenesis.
Thank you, Dr. Ahmad. Fantastic talk. We've learned so much from you. Thank you.
Dr. Mohammed, I'm Professor Sanjeev Reddy. How young you can take the testicular tissue for cryopreservation?
I beg your pardon?
Young, how young age of the patient?
Okay. Usually, because I started this in our country is based on research. So we started at least 10 years and above, 9 to 10 years and above. Because below that, our pediatric surgeon don't really recommend that, because they also have some difficulty in handling the tissue.
Okay, thank you.
Thank you.
Dr. Samir, you can continue.
Thank you very much for the offer. So hope to see you again. Thank you for
Dr. Mohammed. Okay, I think we will close the section then.
Thank you.
Thank you.
Thank you.
Thank you, sir, for a very informative session. And I also thank all our esteemed chairpersons for making the session more interactive. So moving to the next session, it is my pleasure to invite the chairpersons. Professor Vatsala Dadwal, ma'am is Professor, Department of Obstetrics and Gynecology at All India Institute of Medical Sciences, New Delhi, with special interest in high-risk obstetrics and fetal medicine. Dr. Nandita Palshetkar, ma'am is Medical Director, Bloom IVF Center and 8 IVF centers across India. She has 30 years of experience. Then Dr. Renu Tanwar, Professor, Department of Obstetrics and Gynecology at Maulana Azad Medical College, New Delhi, with special interest in infertility and assisted conception. I also invite Dr. Bindu Bajaj, ma'am. She's Professor, Department of Obstetrics and Gynecology at VMMC and Safdarjung Hospital, New Delhi. So may I request, ma'am, Professor Vatsala, to invite the first speaker for this session?
So good afternoon, everyone. Moving on to the next session about fertility and obstetric risk in young cancer survivors. The first talk or a recorded talk is from Dr. Vitale. So can I have his CV, please?
Yes, ma'am, just a minute.
Thank you. So Dr. Vitale Kushner, he's currently Clinical Associate Professor in OBGYN at University of California, Irvine, and he has his fellowship in reproductive endocrinology and infertility. So we'll have a recorded lecture from him.
Pleasure to virtually present. Today I'll be speaking about the challenges during pregnancy for young cancer survivors. As a brief background on myself, I'm a medical director of fertility centers.
technical issues in playing the pre-recorded video. So may I request my co-chairperson to introduce the next speaker, Dr. Bindu.
Hello. The next speaker is Dr. Padma Rekha Jirje. She'll be speaking on fertility and obstetrics risk in young cancer survivors. May I have a CV, please?
I will just be sharing the slide.
Oh, just a minute.
And there's some technical issues. Just So we apologize for the delay. There was some technical difficulty. So now we'll be resuming. So I request ma'am, Dr. Bindu, to introduce the next speaker.
Dr. Padma, she has completed a clinical research fellowship in IVF from Glasgow University. And she is practicing right now in Kolhapur as fertility specialist since 1998. She's an editor-in-chief of Journal of Human Reproductive Sciences. She is a member managing committee, PCS Society of India, and she has she's a national corresponding editor for Journal of Obst and Gynae of India. Welcome, Dr. Padma. Kindly speak on your topic, fertility and obstetrics risks in young cancer survivors. Thank you.
Ma'am,
Dr. Padma, kindly unmute yourself.
Yeah, can you hear me now?
Yes, now you're audible, ma'am. Yes.
Yeah, I'm very grateful for the kind invitation to Dr. Anita Singh and for organizing this excellent academic event. Thanks to the chairpersons for your kind introduction. And I'm very grateful for this opportunity to address fertility and obstetric risks in young cancer survivors. If we look at the currently available evidence, we do know that majority of adolescent and young adult men and women cancer survivors have fertility concerns, and this does have a direct influence on their quality of life. Fertility preservation is considered as a key survivorship issue for these young men and women. So what I would like to do is address the fertility risks in women and men who are young cancer survivors, and also address the obstetric risks in these young people. And we need to bear these issues right from the beginning, from the time of diagnosis of malignancy through the treatment period, following a cancer-free period, and also during pregnancy. So these are the important times where we need to address variedly the issues pertinent to that stage of their management. So we have seen through the day, there are various fertility preservation options available for both men and women, prepubertal and postpubertal. And what they aim to achieve is basically increase the fertility window. If the gonads are irreparably damaged and irreversibly damaged, through various steps of these, we can increase the fertility window for these people to, or shift it to a more suitable period of their lifetime. Now, do we really need to introduce this aspect and pay a lot of attention to this aspect while they're going through another journey of treatment for malignancies and recovery from that? There is obviously an increasing evidence to show the importance of this, and the Scottish Registry, looking at the data from 1984 to 2014, has compiled a huge amount of informative evidence. If you look at the pie chart here,
what it is showing is, compared to people who have never had malignancy, there is a pregnancy deficit because of malignancies itself in these young cancer survivors. And if you see this pie chart, we can see that just carcinoma of the cervix contributes to about 26% of the deficit, and again maybe around 23% by breast cancer. So just between these two malignancies, there is nearly 50% deficit in the pregnancies that could have happened in the reproductive age group. Further, they do show that at an individual level, when we counsel these young people as to the importance of fertility preservation, we do know that there is about 43% reduction in the post-treatment chances of pregnancy. And this we have to address, that it is both a genuine impact of the treatment on fertility, and also, consequent fear factor or other factors which may influence the decision to avoid pregnancy. So how do we address these issues? So if we start looking at the fertility and obstetric concerns, so first addressing the fertility issues, the various modalities of cancer treatment, be it radiation, surgery, targeted therapy, or chemotherapy, can lead to future infertility because of disruption of the hypothalamo-pituitary axis and consequent hypogonadism. And in addition to this, the obstetric issues arise again because of all these modalities of treatment, because of their impact on the uterus, whether it is radiation related or surgery related, particularly in carcinoma of the cervix with radical trachelectomy. Both of these can lead to preterm birth. But one of the aspects we don't normally understand or address is the systemic impact of radiotherapy and chemotherapy or targeted therapy on heart and lungs, affecting maternal cardiopulmonary status. This is something we very often do not understand or acknowledge. So we need to look at two aspects. One is the post-cancer loss of fertility in women due to decline in ovarian reserve because of impaired uterine function, and also disruption of the hypothalamo-pituitary axis because of various modalities of treatment. And also much wider and more worrying is the impact on maternal health, particularly cardiopulmonary. So various drugs can cause arrhythmias, congestive cardiac failure and cardiomyopathy, hypertension, myocardial ischemia, pulmonary fibrosis, and valvular heart disease. So these are the aspects we also need to pay attention to while we are talking about fertility and obstetric risks in young cancer survivors. So when we have to evaluate somebody who has had previous radiotherapy, first and foremost, we need to see is whether the issue of fertility preservation has been addressed before any primary therapy, and whether any cryopreservation of gametes or tissue has been done. So, and also evaluate the current ovarian function. If it is good, then we initiate steps towards achieving pregnancy. If there is ovarian failure, then we have to consider alternative modalities of treatment. If ovarian tissue or oocytes have been cryopreserved, again, they can we can initiate the algorithm for going through treatment to achieve pregnancy. So one of the things we need to do is evaluate the uterine condition, particularly for endometrial thickness, which can be very often affected with previous radiation, and also MRI, which is not something we often think of routinely, but that is something very important to look at the myometrial fibrosis. Having done these, then if they've received any total body radiation or partial pelvic radiation, then we can counsel them and then appropriately initiate HRT. And very important is to consider long-term pentoxifillin and vitamin E regime to improve the uterine health, and then go ahead with pregnancy and monitor the pregnancy very carefully. However, if any of these, along any step of this algorithm, if there is concern about the ability of the uterus to achieve successful implantation and pregnancy, or if they have received whole body irradiation, then we will have to discourage pregnancy and consider surrogacy. Of course, if there is, if the uterine health is considered to be okay, and they have achieved premature ovarian failure, but there is no available cryopreserved tissue or gametes, then another option would be to consider egg donation for these young women. What about chemotherapy? So again, there are concerns about chemotherapy because of the potential gonadotoxic regime. So most of the people who would require future surveillance are the ones who have received alkylating agents, maybe cyclophosphamide, or a combination of chemotherapy and radiotherapy where ovaries are partly exposed. Traditional, conventional way of monitoring ovarian function for any gonadotoxic impact is through monitoring FSH levels and estradiol levels. I think Professor Anderson's talk also showed how much of importance is given to this endocrine monitoring. But increasingly, even though AIIMS is not declared or considered as the hormone to evaluate for assessing ovarian reserve, increasingly there is accumulating data to show that it plays an important role in evaluating the ovarian existing ovarian reserve in these young cancer survivors. What is most important is if they approach us for the first time, who are the ones who need to be evaluated post therapy? These are the ones, I mean, those who do not have any signs of puberty by the age of 13 years, those who have primary amenorrhea at 16 years of age or beyond that, or where they've achieved puberty, but then there is amenorrhea, where there's failure of pubertal progression. So these are the subsets of women who need to be evaluated for their residual ovarian function. And then, if they approach us, not during this stage, but directly for concerns regarding pregnancy later in their life, of course, they need to be evaluated as well. So if you look at how do we proceed following evaluation of the ovarian reserve in those who have received chemotherapy, similar to radiotherapy, it is very important that we establish whether they have existing ovarian function and whether it can be utilized to achieve pregnancy, or if they have preserved their gametes or ovarian tissue. And at the same time, they need to parallelly go through assessment for their general health, for cardiac function, if they've received anthracyclines or molecular agent exposure, if they've had chest irradiation, for hypertension, particularly those who have undergone treatment for Wilms tumor, treated with abdominal irradiation, for gestational diabetes and also preconceptional diabetes, if they've had abdominal irradiation, and also those who have had cranial irradiation, we have to be concerned about possibility of spontaneous pregnancy loss, and those who have received abdominopelvic irradiation with increased risk of miscarriage and premature delivery, low birth weight infants. So all these highlight to a very methodical and multidisciplinary approach for achieving successful pregnancy outcome. Now this slide refers to the same data I showed from the Scottish Registry earlier. It shows about they have not looked at the nature of treatment if anybody has received during the observation period or the follow-up period, but they've looked at the data of nulliparous women achieving their first pregnancy post treatment for cancer, and particularly in those below or up to 39 years of age, and compared to controls who have never had any malignancies or any therapy for that, from the duration of 1981 to 2012. So it's a very comprehensive data. So looking at cancer affected women further achieving pregnancy 2071, and those who never had malignancies, it's about 117,000. So if you look at the miscarriage data, the percentage of miscarriage is very similar in both these groups, very heartening. And termination of pregnancy for any fetal abnormalities. What is very interesting is there is definitely no increased risk in those who had malignancies previously. In fact, there is a significant decline in the risk of termination for any abnormalities. Stillbirth, live birth, and infant death all appear to be very similar. So it is extremely important. This study highlights that because they seem to have the similar obstetric outcome compared to their controls who have never had malignancies. Again, it reiterates the importance of identifying those women who would benefit from fertility preservation prior to primary gonadotoxic therapy, and subject them to expose them to reproductive counseling. But if they've already received the treatment, then establish the diagnosis of ovarian insufficiency as early as possible, treat it, and provide them access to ART at the right juncture. Now, what about those who have had malignancies, recovered from it, and eventually have gone through ART treatment? What is important is this study, again connected to the national data from the US, the data registry from in the US, shows that there is no difference. Those who had residual ovarian function, there is no difference in the number of oocytes retrieved or the proportion of the oocytes which fertilized between those who had history of malignancy and those who did not have a history of malignancy. But those with previous malignancy required a higher total dose of FSH, indicating some amount of ovarian decline in the ovarian reserve. Among those, autologous cycle in women with history of malignancy were less likely to result in an ongoing intrauterine pregnancy compared to those who never had any history of malignancy. And this was not seen in those with donor cycle. So that again indicates some amount of compromise in the ovarian function. However, even in those who underwent donor oocyte treatment with donor oocyte, there was an increased risk of pregnancy loss. So that we need to watch for both ovarian and uterine health in these women who undergo ART. So we need to, the take-home messages from all this evidence available is the survivors should be counseled that their fertility and likelihood of having births after cancer are lower, but most will have a residual window of ovarian function and fertility of after primary cancer treatment. As data estimating the remaining fertility window is not available, survivors after cancer treatment, once it is considered okay to go ahead with pregnancy, should consider attempting pregnancy earlier than delaying it. As far as their reproductive health is concerned, those with history of receiving anthracycline or chest irradiation are at an increased risk of developing pregnancy-associated cardiomyopathy, and they need to be, the absolute risk is low, but the clinical consequence can be very worrying, and hence they need to be subjected to pre-pregnancy cardiac evaluation for these subset of women. And there is a higher rate of preterm delivery and low birth weight neonates among the young adolescent and young adult cancer survivors, particularly those exposed to abdominal and pelvic irradiation. The increased risk can be as high as 2 to 3-fold, and hence they need to be watched for this these complications. Limited and inconsistent data exists on the risk of gestational diabetes among female childhood cancer survivors. Of course, in our country, as such, the risk appears to be higher than Caucasian population. So we need to watch for occurrence of this problem as well. Overall, rates of birth defects among childhood cancer survivors are low, do not appear to be increased compared to general population. So they, as far as evaluation for congenital abnormalities are concerned, they should go through the same level of observation and monitoring as those who have never had malignancies in their lifetime. Childhood cancer survivors who underwent CNS or chest radiation might experience more problems with breastfeeding compared to healthy controls, and will need additional support and additional attention to this aspect as well. There's no increase in the risk of childhood cancer in offsprings of these cancer survivors. And if you remember in the very first or second slide, I did say that some of them actually avoid pregnancy because of various other concerns. And one of the reasons is this fear of their child developing malignancies, and the current evidence doesn't support this problem. So what about male survivors? If semen banking has not been done, we do know that microdissection, testicular sperm extraction, microtissue, is still an option for these people who wish fertility. Approximately 37% of them may have some residual sperm available once they're subjected to this microdissection tissue, and many of them may achieve pregnancy. Fertilization rate of up to 57% and a pregnancy rate of about 50% has been achieved through this process. So what is very important to convey as far as young men who are cancer survivors is that the potential harm to sperm DNA integrity from cancer therapies, especially in the era of ART, which has allowed use of sperm that would not otherwise be capable of naturally fertilizing in oocyte, has led to concerns about the health of offspring. And we need to provide a particular length of cancer-free, treatment-free period before we attempt to retrieve these sperms, which is approximately, about a year post radiotherapy or 2 years post chemotherapy as a general rule. But depending on the modality of treatment used, it may vary depending on the particular agent used. So to put it in a nutshell, counseling plays a very important role and is an integral part of the treatment of these young cancer survivors while they wish to preserve their fertility, promote their fertility, and achieve pregnancy. So different specialists will be involved at different stages, but should be a continuum. Multidisciplinary involvement is very important, and sensitization of the team members from various specialties is very is need of the hour. At diagnosis, during or following treatment, when considering a pregnancy or during pregnancy, they do require supports from different disciplines. And also we have to acknowledge that at any given time, if the person wishes, we need to be able to provide appropriate counseling. Majority of the evidence show that different standard and experimental options for fertility preservation do increase the fertility window or offer fertility at an appropriate stage for these young people. Very little evidence on future fertility and treatment option needed is available at present, and little evidence regarding reproductive management of male adolescent and young adult survivors, even though, as we have seen, recent years have seen some progress in this sector as well. Population-based studies indicate a reduced chance of pregnancy in young cancer survivors. Fertility preservation, timely evaluation and guidance may improve fertility in this population of both men and women. Maternal health concerns remain a challenge following certain treatment modalities, and pre-pregnancy evaluation and management in dedicated obstetric units geared up to provide these additional facilities is very essential. Thank you.
Yeah, Padmarekha, this is Dr. Nandita Palshetkar. Very beautiful talk. It was really very all-encompassing. Are we having question answers now, or are we having that talk?
After the talk.
Okay.
So we have one more talk.
Thank you, Nandita.
Yes, ma'am. We'll try to play again the recorded PPT by Dr. Vitali Krishna. Meanwhile, we can take the questions, ma'am. What do you say?
Yeah.
Oh, we can go ahead with the questions while they set up the video for the next talk.
Thank you, Nandita, for joining. Good to see you.
Yeah, thank you. Thank you, Neeta, for inviting me. I think I have one question for Padmarekha. Padmarekha, you said that, you wait for 1 to 2 years post therapy for the man. For the woman, how long do you wait if she's not frozen her?
It's the same. It's the same.
You have to wait for a year or 2 years?
Radiotherapy 1 year and chemotherapy 2 years. Because
okay. And another thing, pardon?
Yeah, from the initiation of therapy. Yeah.
From the initiation of therapy. Okay. And from the last dose taken, anything like that? Or?
I think, there doesn't appear to be a consensus or enough amount of evidence at present, Nandita. So it would basically depend on the type of chemotherapy used. Yeah. So it has to be a decision taken along with a medical oncologist.
Okay. And I also wanted to ask you one more question. If it's a breast cancer patient, you've frozen the fertility and it's estrogen progesterone receptor positive, would you advise pregnancy in that patient? That's always a question which is...
Very, very true. I think this is, if we have actually done fertility preservation in these women, probably it is comparatively easier to handle this situation. Overall evidence does show that after a cancer-free period, they would be allowed to conceive naturally. So similarly, any treatment, as long as it doesn't lead to supraphysiological levels of estrogen, after we have followed the stipulated cancer-free period, we should be considering this option.
Yeah, because generally even now the consensus is that you can stimulate the patient with even letrozole, gonadotropins, that a little bit increase in E2 doesn't really cause any deterioration of the disease. So I think we can promote oocyte freezing in them either prior to surgery or even
before
post.
Post surgery, before chemotherapy is a good time to consider these procedures.
There was a very beautiful article by Anna Kobo, which actually she said that even freezing after therapy for these cancer patients is good enough. You must do it. What is your opinion on that?
If we see if they're cancer free and they have residual ovarian function and still they're undecided about fertility, that this is an option that should be offered to them at that time. If they have good reasonable ovarian function and not keen to conceive at that moment, but we know that the reproductive window is short. So to make the maximum of that, we should offer them post-therapy as well.
And I think even PGT-M you can offer them so that if there are any hereditary cancers, because young patients usually with cancers would have a lot of hereditary cancers, and you can offer PGT-M.
So if they've undergone the assessment beforehand.
But I think assessment, would you advise it in all the patients? Don't you, do you feel it's necessary?
I mean, if we have, if the BRCA mutation assessment has been done, then offering any PGT-M, it will be a continuum of such assessment. So if we know that she has an increase or she has these mutations, then it makes sense to take care of the offspring to prevent that problem happening in the next.
To pass it on to the next generation, you can actually prevent it. So I think that is a very important message which you can give everybody, that you can actually prevent it from going from one generation to the other. Okay. Any other questions? I don't know in the chat if there are.
Hello. Hello, Dr.
Yes.
Padma and Dr. Renu this side. Can I just ask you one question? Thank you. Your presentation was beautiful. I just want to thank you for bringing this into picture that cardiomyopathy, these patients are increased risk for cardiomyopathy. I have just one question to ask you. Is there any cutoff for this left ventricular function to be done for this cardiomyopathy so that we can advise these patients that they should not consider pregnancy or that? Is there any cutoff in the literature?
I haven't come across any guidelines to say that we should follow a particular level. I think a good clinical practice would be to have an evaluation, pre-pregnancy evaluation by cardiologists who are aware of these problems. I mean, the whole thing is, it has to be a multidisciplinary approach. There has to be an understanding of these risks because of gonadotoxic therapy. I mean, because of chemotherapy or radiation happening on the chest, cardiopulmonary health. And I have not come across any guideline or any particular cutoff value. But I think pre-pregnancy evaluation would set the tone for pregnancy management.
Yeah,
because I think
I
the
think
absolute risk, they say, is very, very low. And we haven't experienced any of this problem. We have never seen this problem. Of course, the experience is very, very limited, I think, at individual level.
yeah, because usually we are not going for an echo. The patient is young. We think just only the ECG could be better. But when I was going through the literature, I found this line that if the left ventricular function is less than 30% before the pregnancy, that means these patients should be at high risk for cardiomyopathy when they continue with the pregnancy. Thank you so much.
Thank you. Thank you. Shall I think, yeah, I've stopped.
I think, Padma, we are not going to leave you because we haven't yet got the next speaker on. So let's talk about ovarian tissue cryopreservation, Padma. Okay. No, in young adults, I think we can just talk till they tell us to stop. So Nita, please let us know when we can.
No, so we are trying to,
but you can.
Technical problem. So Dr. Vitali's talk, a brief talk on fertility concerns and pregnancy issues in the cancer survivor. So Dr. Kushner is from California. So there was a time zone gross disparity. So he pre-recorded and sent it to us. So we're going to play his talk.
Hello, I'm Dr. Vitaly Kushner, and it's a pleasure to virtually present at this conference. Today I'll be speaking about the challenges during pregnancy for young cancer survivors. As a brief background on myself, I'm a medical director at West Coast Fertility Centers and associate clinical professor at University of California, Irvine. I'm a reproductive endocrinologist, so I primarily specialize in fertility treatments. And I'll mention both pregnancy related issues after fertility treatments for patients who have survived cancer, as well as methods of fertility preservation and available options for these patients. Brief disclosure, I do have pending patents related to the clinical use of anti-Müllerian hormone, and I'll briefly describe some of that in my talk. So I think it's important to recognize just how prevalent cancer is, and here I have statistics for the United States. As you can see that each year there are more than 1.6 million new cancer cases diagnosed in the US and close to 600,000 deaths. The cases can be broken down, of course, by gender and type of cancer. And as you can see, the most common amongst women is breast cancer, which can affect women of reproductive age. Other cancers that are fairly common are ones like leukemia and lymphoma that are also happening often in reproductive age women. Likewise in men, you can see that some of the cancers that are happening in men can affect them during the reproductive years. What's important to also note is that there are each year close to 16,000 new cases in young patients under age 19 that are diagnosed. And because cancer survival rates have been improving gradually, and there has been an increased emphasis on the quality of life, we've seen a shift in the way that doctors and patients think about cancer survival and cancer treatment. And especially now that we have successful fertility preservation options that have been developed, and many patients are now thinking more about post-treatment parenthood options. And so we have to be very cognizant to offer patients accurate information about their fertility options, risks, and try to coordinate this as best we can with their oncologists and assure that the patients receive the best possible care that's comprehensive. And of course, the societies in not just in the fertility field, but also in the oncology field very much recognize this. And ASCO issued these clinical guidelines now more than a decade ago, which clearly state that as part of informed consent prior to therapy, oncologists should address the possibility of infertility with patients as early in treatment planning as possible. And certainly in my practice, I have seen an increase in newly diagnosed cancer patients coming in. Just within the past week, for example, I've seen a young male patient with testicular cancer. I've seen a young female patient with breast cancer and patients with early stage ovarian cancer where one ovary was removed. I also recently saw a patient with early stage endometrial cancer. So there's many of these patients out there, and I think we have to be really cognizant to make sure that we are really understanding what their needs are. So as far as pregnancy after cancer, this is a very nice study that was published in The Lancet. And as you can see here, this looks at siblings, patients who had cancer and their siblings who did not. And as you can see that for the sibling that was affected with cancer, generally their chances of having a subsequent pregnancy is substantially lower, and chances of having a live birth is substantially lower than their siblings who never were diagnosed with cancer. And there could be a multitude of reasons for that. It could be that the cancer treatments are affecting their fertility. It could be that the cancer itself is affecting their fertility, or whatever it was that predisposed them to develop cancer is affecting their fertility, or maybe that they're just not they're choosing not to have children after cancer survival. But it's important data. Now, as far as parenthood in cancer patients, the first-time probability of parenthood at age 35 was substantially reduced in female cancer patients versus the general population. And these early studies also documented that there's increased risk of various pregnancy complications, including low birth weight, preterm delivery, and perinatal mortality. This was one of the very first studies that had looked at this. And I'll show a lot more data here in a minute. Now, as far as pregnancy after cancer, it seems that cancer does not trigger recurrence even in the case of breast cancer. So that's very important information that patients need to know. Although it's true that growing follicles may be damaged by chemotherapy or radiation therapy, but primordial follicles are often spared and can produce healthy eggs down the road in 6 months or even several years after being exposed to chemotherapy. And additionally, it's very important to understand the type of treatment that the patient had, because certain chemotherapy can be damaging to the heart and the lungs, and that can, of course, affect the patient's ability to safely carry the pregnancy. And all of that added stress can contribute to the complications of pregnancy. Now, children born after cancer, it's reassuring to know that the birth defect rates in those children is the same as it is in the general population, and there does not seem to be any increased risk in genetic disorders like Down syndrome or Turner syndrome in children who were conceived to cancer survivors. And also there has not been really any documentation of unusual cancer risk that's been identified in offspring of cancer survivors, with the rare exception of patients who are true genetic cancer syndromes, which may be, of course, inherited in their children. And here's data to show this for various different kinds of disorders: cytogenic syndrome, single gene disorders, simple malformations. The data overall is very reassuring, is that in that there does not seem to be any substantially increased risk. Now, this is a very recent meta-analysis that was published just a few months ago, and it looked at a very large sample size. And here there were this was primarily focused on breast cancer survivors, and there were patients in the medical literature that had pregnancies after breast cancer, and there were over 7,000 such patients. What the study found is that breast cancer survivors were 60% likely to have a pregnancy than women in the general population. So again, documented lower fertility after cancer. And they again documented the pregnancy-related complications were more common in survivors, in that they had more risk for low birth weight delivery, preterm delivery, or having a baby that was small for gestational age. But what's reassuring is that most survivors who did become pregnant have healthy babies, and there also did not seem to be any adverse impact on long-term maternal survival, and there was not any increased risk of cancer re-emergence after pregnancy. So that is very reassuring information.
Thank you very much.
So here we close.
I think it was a beautiful session. Congratulations, Dr. Neeta. Wonderful, wonderful program and fantastic speakers.
Since there's no questions in the chat box. Last session. So we'll close the session, then take up the next session. Thank you so much. Thank you, organizers, especially Dr.
It was a wonderful session. Thank you, chairpersons and dignified speakers. We now move on to the last session of the day. For this, I invite our chairpersons, Dr. P.M. Gopinath, Director and Senior Consultant, Institute of Obstetrics and Gynecology and IVF, SRM Institute of Medical Sciences, Chennai. Dr. Priya Kannan, Scientific Director at the Garba Rakshambigai Fertility Center, Chennai, Tamil Nadu. And Dr. Pratap Kumar, Professor and Head, Department of Reproductive Medicine and Surgery, and the member of Task Force of Human Development and Disease Biology, Department of Biotechnology. Over to you, sir.
Good evening. And it was indeed a very good academic session. And moving to the last talk, it is a hot topic today. There's a lot of hue and cry about the ART and surrogacy bill. Particularly in terms of fertility preservation, we have been more concerned. We have given our representation, and we have just informed the government about all our concerns, and they have been taken care of. And then they said they will just get back to us for the correction. So with that in mind, we have with us our eminent speaker, Advocate Hitesh Bhatt. And he is practicing in Andheri, Mumbai. And he is a medico-legal consultant since about 20 years at Vadia Maternity Hospital and Central Railway Hospital, Mumbai. He is also a partner in legal firm B&S Medico-Legal Consultancies. He was a past chairman of the Ethico Medico-Legal Committee of FOXY, and he has authored several books. A good friend of mine, and he has been associated with my Center on Medico-Legal Auditing for the past, say, 5 years. And he has got a very clear thinking, and he's going to explain everything. Probably all of you will have a lot of answers, questions to ask him. Please put it in the chat box, and he'll be too happy to share with it. Over to you, Hitesh.
Apologies for the technical glitch. We are waiting for Dr. Hitesh to join. It will take a while, sir.
We have Dr. Pratap Kumar is there.
I think I can see Dr. Pratap, sir, there. I had seen him.
Pratap, Pratap, are you there?
Yes, he's there.
I'm there. Hi, how are you?
Hi, Pratap. How are you?
All good.
And see, you have been until we hear from Hitesh to Hitesh, you have been with us even from the formulation of this act for a long time. So can you just give your comments on this current views until Hitesh joins?
Yes, sir.
Dr. Hitesh has joined, sir.
I think after Hitesh's talk, I'll give. Yeah.
Good.
Hitesh, welcome to you.
Hi,
You start your
Hitesh.
talk.
Welcome.
Hello, sir. So, just I will start my presentation, sir. Can you give me, okay, I think I'm able to, can you give me rights to share my screen? Okay.
I think you already have, you can do screen.
Okay, fine. So, thank you for inviting me and allowing me to share my views on this topic. I hope my slides are visible and I'm audible, right?
Yes. Go ahead.
Sir. Okay. So the thing is, if you see there was no act before the 20th December 2021 as regards the ART and surrogacy is concerned. So on 20th December, the ART Act was enacted, it was gazetted. And following that, there was mention in the Act that it will be enforced at a later date and it will be separately gazetted. And that happened on 25th of January. So on 25th of January, this ART Act came into force. Now, before that, we all were, and all the doctors were happy like this. But since the Act was enacted, they started looking like this. They started fearing it, right? Because there were punishments in it. So, but actually what happened, we had so many guidelines, we had so many bills from 2010, 2014, 15, 17, 19, 20. So it was like the practice of ART was like a dark tunnel. But after this, actually, we have seen some light at the end of the tunnel. And that is actually, in fact, a good thing. So ART Act 2021. Now, what is the impact of the ART Act on the fertility preservation in young cancer population? That is the topic given to me. So let us see. If you see the preamble of the Act, it mentions that it is an act for the regulation and supervision of the assisted reproductive technology clinic, banks, prevention of misuse, safe and ethical practice, and it also says freezing of the gametes, embryos, embryonic tissue for future use due to infertility, disease, or social and medical concerns. So they have included the social freezing into the preamble of the ART Act. So we were thinking that the social freezing or the freezing of the oocyte for fertility preservation is separate from ART, but they have now included into this act. But they have not defined it anywhere. If you see the definition of ART, ART mentions that all the technique that attempts to obtain pregnancy by handling the sperm or oocyte outside the human body and transferring the gamete or the embryo into the reproductive system of a woman. That is ART procedure. Now, what about fertility preservation? Because the aim is not to transfer the gamete or embryo back into the reproductive system, at least at that point of time. ART bank they have defined, ART clinic they have defined, But who can give the treatment for fertility preservation? That is not defined. Commissioning couple they have defined. And also they have said in the act that the ART Act did not define the fertility preservation, but by general understanding, the definition of fertility preservation, we know the fertility preservation is the process of saving or protecting eggs or sperm or reproductive tissue so that a person can use them to have biological children in future. Now, that type of definition should have been there, which is not there in the ART Act. Now, person who can take the treatment, they have said that who can take this fertility preservation or who requires fertility preservation, those who are exposed to, we know all the indications, right? And we at present, we are concerned about the treatment for the cancer. And there are options to fertility preservation. We can go for gonadal shielding, we can go for ovarian transposition, or we can go for sperm cryopreservation, oocyte cryopreservation, or embryo cryopreservation. These are the options. But if you see this ART Act, Section 2021, Section 21, in the duties of the ART bank and clinic, it has mentioned that the clinic shall apply ART services to a woman above the age of 21 years and below the age of 50 years, to a man above the age of 21 years and below the age of 55 years. Now, what should we presume? Does it include fertility preservation? We can say that ART Act is not clearly separated from the fertility preservation. However, in the preamble, they have included it. So if somebody requires fertility preservation before the age of 21, what is the recourse? There is a defense in that case. We can say that it is for the ART service. And ART service is very well defined that the intention is to put back the gamete into the genital tract to achieve pregnancy. So we can say that our aim is not that, and that is why we have treated a patient who is less than 21 years of age. But that is a defense. There can be a case filed against you if the appropriate authority is not understanding this difference. This is the argument before the court. So it was very much necessary to define fertility preservation procedures and to add one line in this law that the fertility preservation procedures are all these sections will not be applied to fertility preservation. That is not there. We missed at that point. So as we have seen the definition of fertility assisted reproductive technology, it says to attempt the pregnancy by putting the gamete back into the genital tract. And that is not our immediate aim in fertility preservation. If you see section 22 of this ART Act, that says that the clinic shall not perform any treatment or procedure without the written informed consent of all the parties seeking ART. The clinic and bank shall not cryopreserve any human embryo or gamete without specific instruction and consent in writing from all the parties seeking assisted reproductive technology in case of death or incapacity of any parties. This is what is the section. Now, what about fertility preservation? That they have not said whose consent. Whose consent will you take if the person is less than 18 years of age? Naturally, guardian. Now, if you take the consent of guardian, mother is a guardian, father is a guardian, or both? What if there is conflict between both the parents? What if there is a conflict between the guardian and the person who is taking treatment? Can guardian refuse the fertility preservation treatment if the boy of 17 years want to preserve, but the parents refuse? What to do in that situation? What if the child refuses and the parent agrees, or vice versa? So that things are not clear because they have not mentioned fertility preservation in this act. If you read section 28, the gamete of a donor or embryo shall be stored for a period not more than 10 years. Now, if fertility preservation is a part of this ART Act, and if you want to preserve this embryo or gamete for more than 10 years, what to do? Here also there is a catch. It is mentioned gamete of the donor or embryo. That means the self gamete can be stored for a longer time. But that is again a defense. It is not clearly mentioned in the law. This is the inference as a lawyer which I have taken out. That can be helpful as a argument in the court. But will it prevent any litigation against you? I am not sure. Because we have seen in PCPNDT, most of the appropriate authorities are inappropriate authorities. They don't understand the concerns and they are selling the machines left, right, and center without understanding the purpose behind it. And Supreme Court has so many times, and many high courts have noted that these cases are registered against the doctors without giving due thinking on the offenses. Now, after sperm preservation, if the person dies, then if he or she is not married, what to do with the gamete? Because if fertility preservation is a part of ART, this point should be addressed by the ART Act. What to do with that sample? Can his or her parent ask for it and they can use it in ART to have their grandchildren? Because the right to reproduction is not a fundamental right. Nowhere it is mentioned. If at all it is a fundamental right, it is limited to the couple to have their own children. And certainly not to have the grandchildren. Even if it is a fundamental right, it doesn't extend to have a grandchildren, right? So usually we can say that after the sperm or oocyte preservation, if the person dies, if he is married, then can the sperm or oocyte be retrieved posthumously if they are married and to be used by surviving partner? Section 24 says that the collection of the gametes posthumously can be done only if prior consent of the commissioning couple is available in such manner as may be prescribed. So that is now allowed. But what about unmarried person taking the treatment for some disease? This suggests that the intent of the lawmaker is very clear, that if the person is single and if he or she dies, his or her right to reproduction will die. And that is what happens. All the rights of a person dies with his death. So his right will die. And that is why they have not put it in the ART very clearly that it can be used. So if the semen or oocyte sample is frozen and if the person dies, now it is clear that the kin, next of the kin or parents can take it. If the person is not married, they can take it, but they can keep it only as a souvenir. They cannot use it for any purpose, not for having the children. So that is it. They cannot even donate it.
The chat box.
They cannot give it for donation as well. Because it is said that the next of the kin can donate organs of the dead person.
Thank you,
if they wish,
Dr. Anita,
but they can't
for giving
donate
us
the
this
gametes of
opportunity.
a person because there is a succession act attached. If the gametes are given for donation, the child is born, the child will inherit all the rights of the property and all. So that is why it is, I think they have kept it separate, and you cannot, because by giving the genetic material in donation, you are producing a new child. While giving the organs for donation, you are not creating any new person. That person is already having his own rights. So that may be the intent, but it is not very clear from the ART Act. So what is the impact of the ART Act 2021 on the fertility preservation in young cancer population? We initially thought that ART Act shall address the issue, but it did not, except in the objectives. Now we still have to wait. And wait for what? Wait for the ART rules. If this issue is addressed in the rules, well and good. And we will see, because there are many representation, and I hope some good body like Foxy or ISAR or whosoever, they might have represented this issue as well, and they will get some idea or some rules in the ART rules which have yet to come. If not, then we are back to square one. I think we are not back to square one, because previously we were only confused, right, before 2021. Now they have added this into objective, nothing put in the law, but there is a punishment put in the law for doing any wrong thing. So now we are having this sword hanging on our head by doing fertility preservation and attracting the punishment under the ART Act. So we are not into back into square one. We are into a worse position. So with that, I think I stop my presentation. Thank you very much for patient hearing. And these were the concerns with new law.
Yeah, hi, Hitesh. I would like to tell yesterday when we met the Deputy Director of Health Services, so
Yes.
they have said that because the fertility preservation has not been addressed in the Act, that is going to come in the rules. And so whatever is meant for ART will not apply for fertility preservation.
That is what that should have been in the main act. And
Yes,
definition also should be there in the act.
Yes, but they had not put but they have listened to us and they have said that it's going to be put in the rules that fertility preservation is an exception to this.
Exactly. So if that happens, it is well and good, madam. And that is what was required when I...
They have written all the points, whatever were told by us.
So that I had given in writing to even this Prakash Trivedi sir on the first day when this act was enacted. And I said, we have to represent this.
No, Dr. Nalini and myself represented FPSI.
Okay.
So through FPSI, we have already given them and they have told us that they have incorporated what all we have told them.
Okay, perfect.
Hitesh, they are very keen on listening to us and asking us for our help. So if you give the written stuff to Prakash, Foxy is actually collating it together. I think Dr. Shantakumari is collating it together so that we can give one set of instructions to everybody.
Right.
So I think it will work, the Fertility Preservation Society and, all of us.
IFS, Fertilization and ISAR together will do all the things.
Yeah.
Right.
Thank you very much, Hitesh, for the nice talk. And I think Madhuri Patil clarified the point that we still have to wait for the rules and regulations to come out because it is not mentioned in the Act. But I think it makes sense because many of the young pivotal girls and boys are needing that cryopreservation. So at the moment, we can cryopreserve, I suppose, but not use them later because the survivals are very high nowadays. So I think when the rules come up, we will be able to follow the instructions later. But at the moment, we can cryopreserve because it's for cancer management.
Yeah, the first set of rules they will release on end of this month.
Okay.
That's what they've said.
Yeah.
And therefore, the input has to be given by Tuesday. That's what they have said. So I think whoever has any input can either pass it on to Foxy or ISAR or IFS, either of the three bodies, and it would be collated together and then given to them.
Thank you, sir. You made this very interesting. So thank all the speakers and the chairpersons for the session. So by this we come to the end of this excellent CME. I would like to thank all the distinguished speakers and chairpersons who blessed us with their knowledge. I extend our deepest sense of gratitude to Professor Anita Singh, ma'am. Words are not enough to thank your constant guidance and support to shape this CME. This will be incomplete without mention of all the faculty, residents, and entire staff of the ART division who always stand by us and motivate us. My sincere thanks to the entire audiovisual team, and we are thankful to one and all who joined us both virtually and physically to make this a success. Thank you. Thank you, everyone.
Thank you, Nita, for inviting us, and all the best to everybody.
Yeah, thank you all the chairpersons and speakers who joined us online and offline, without which this academic feast was not possible. Thank you very much for your cooperation.
Thank you, Nita.
Dr.
Thank you for organizing it on behalf of FPSI, and it was a great event with both national and international faculty, and I really appreciate and then congratulate you.
Thank you, sir. Thank you so much. I especially want to thank Madhuri ma'am and you and Nalini ma'am to having trust in my abilities and guiding me through this CME. Thank you very much. So we would be winding up. So we would be switching off the audio visual. Thank you once again, everyone. I would be requesting all those who are present in the auditorium, kindly stay on for 5 minutes more. So one of our so lovely, pretty, charming faculty, Dr. Nilanchali, it is her birthday today.